working like this for quite a long time now.
Yes, I saw her only in the Kochi conference, sir.
And I'll be back in a minute.
Yes, sir.
Sir, we are almost live. Okay, we are going to live. Just give me 2 minutes.
Vidya.
Yes, sir.
Did you have any training with Dr. JKR, sir, also?
Yes, sir. Throughout the 4.5 years, JK sir was there all the time. He would come at least 2 to 3 times a month.
So he's been a sort of mentor for all three of you then. It's fine.
Yes, sir. And whatever surgeries, anything for swallowing or anything we've done, I show to him and he gives us some of approval or what to do. Like arachnoid adduction needs to be done, he'll tell, you should do that along with me, like that. So he's been a mentor too, sir. Yes.
Right.
The only drawback of the webinar is I'm running out of new slides.
That I think after some time people get bored. I mean, if like common, especially I think faculty members is the biggest torture. Because sometimes you are common faculty members in many webinars. So yeah.
So from next year, we have to make a new PowerPoint presentation because it will be repetition because everybody has seen the recordings, sir.
Correct.
Another editing and archiving over the last 6 months, because I got so much of free time.
Yes,
and to my astonishment, I have 5,000 videos on my computer.
You should do an atlas next.
Good evening, everyone.
Good evening.
Sir, start for me.
Biswajit.
Yes, sir. Yes, sir, we can live. We are live.
Yeah, it's 6:02. Can we start?
Yeah.
Yes, sir. A very good evening to all of you. I, Anjana Talukdar, on behalf of Pratiksha ENT Academic Group, extend my warm welcome to everyone. At the outset, I would like to inform you that the inception of this academic endeavor was by Dr. Gautam Khan, sir. We have embraced all ENT consultants of Pratiksha and Nightingale Hospital, and also speech and audiologist team of Pratiksha and Pratidhwani Clinic. We have carried out academic activities on first Saturday of each month. And during COVID pandemic, we carried out webinar online as per schedule. My sincere gratitude to all the participants and viewers for making this venture successful and looking forward for continuing so. So today, to earmark the first anniversary, we have organized a symposium on swallowing, normal and pathological aspect, and live demonstration of FIS. We have guest faculty, Dr. Sanjay Subaya from Bangalore and Dr. Vidyadharan S. from Chennai. And local presenter is Dr. Priyam Sharma. She is from Nightingale Hospital. And live demonstration of FIS by Dr. Biswajit Gogoi is from Pratiksha Hospital. Moderator of the session is Dr. Gautam Khan, sir. Sir, an academician and surgeon par excellence, Dr. Gautam Khan, sir, is the HOD and chief consultant of Nightingale and Pratiksha Hospital and visiting consultant at Apollo International Hospital, Guwahati. And let me read some lines from his prolific biodata. Sir is member of the governors of Indian Academy of Otolaryngology and vice president of Association of Phonosurgeons of India. Over to you, sir.
Thank you, Anjana. A very good evening to everyone. We are fortunate that we could run this academic activity of Pratiksha Hospital Academic Forum. It was mainly because of Anjana's perseverance that it went on for all the 52 weeks. And today we are celebrating it by doing a swallowing symposium. And we have got very good speakers. Priyam is our own resource person from Nightingale Hospital. She will be speaking first, and we'll have Dr. Sanjay Subaya from Bangalore. We'll introduce him again, and Dr. Vidyadharan from Chennai. But it's most important, as you can see in your screen probably, Professor JKR Menon, the person who is a mentor for all these three speakers actually, and the person who actually brought the, the knowledge of the science of swallowing, and it popularized it all over India. And we now, it's been sort of recognized as a separate entity in our Association of Phonosurgeons conference. From being a 1 hour lectures, it has now gone off to a half day or 1 day, whole day program on swallowing. So that way the subject has risen, and it definitely deserves, because any book on swallowing that you read, everywhere it always mentions, apart from breathing, swallowing is the most next important. You can live without hearing, you can live without your vision, but you cannot live without swallowing, and it makes your life miserable. So in order to understand more about the mechanics of swallowing and the pathological aspects, even though I have been told as the moderator, in true sense, the moderator will be Dr. J.K.R. Menon sir. He is the mentor in chief of everybody, and sir will actually, take the rough questions and try to give us more insights. Priyam Sharma, who is a consultant at Nightingale Hospital at present, she did her MS and MBBS both from Guwahati Medical College, and she worked as a registrar at the Barpeta Medical College for a while. Then she joined as a fellow of the Indian Academy scheme in Nightingale Hospital, and stayed back as a consultant. In between, she has done her training on swallowing with J.K.R. Menon sir when he was still at AIIMS, before he started his laryngology group hospital. And with sir's guidance, actually, Priyam has been doing a lot of work on swallowing in Guwahati. And with these few words, I'll ask Priyam to give a lecture on the basics of interpretation of fees. Sorry.
Thank you, sir. Thank you so much. I'll start sharing the screen now. I hope my slide is visible, sir.
Yes.
Yes, Priyam.
Okay, so very warm regard to all my senior teachers present here, and thank you to the Pratiksha ENT Academic Group for allowing me to speak on this rather new topic, especially in the Northeastern region. So today I'm going to talk on fees, fiber optic endoscopic assessment of swallowing, and how do we interpret it. So in the introductory part, fees was first introduced by Langmore et al. In 1988. And it is basically a fiber optic laryngoscopy, which requires passing the scope into the patient's nostrils, and then we go into a position just above the epiglottis. And then the patient is fed with dyed liquid and semi-solid food. And we note the passage of the bolus and whether any residue is present, or whether the bolus has found its way to somewhere it shouldn't go. Fees basically allows us to have a static and dynamic evaluation of upper airway and digestive tract. So when do we need to do fees? Patients who are having frank complaints of difficulty in swallowing with bouts of cough or choking while swallowing, or they need to do multiple swallows in order to clear a single bolus, or they are having wet hoarseness, that is just after having food or water, they are complaining of hoarseness for some time. Also, pre and post-treatment patients of head and neck oncology, patient with history of neurological deficit who are now having difficulty in swallowing. Also, a random patient with shortness of breath, spiking fever, and aversion to eating, which are not otherwise explained by any other disease process. Now, who can do fees? Basically, any ENT specialist who knows how to do a fiber optic laryngoscopy can do fees with a little bit of training. And trained speech language pathologist also under guidance of ENT specialist can go for this test. What do we need to do before doing fees? First, we need to check the patient's mental orientation, whether they are in a mental state to understand our commands and do accordingly the swallowing therapy as advised. check if the patient is ambulatory or not. If not, then we need to advise for the portable fees that is available at some centers. General examination, apart from the routine blood pressure and pulse rate test, importance to be given to chest auscultation is very important, because if the patient has already onset of pneumonia or lung problems, then this will be a very unfavorable prognostic indicator for the patient. Cranial nerve examination with spatial emphasis on trigeminal, facial, vagus, glossopharyngeal, hypoglossal nerve is important. Oropharyngeal examination, where we look for the sensation of the pharynx, the gag reflex, the bite reflex, and neck examination to rule out any neck adenopathy and looking for laryngeal elevation. How do we prepare for phase? First of all, we need to explain to the patient what we are going to do in the procedure. It's very important to explain to the patient that there may be some coughing episode or some amount of choking while feeding the patient, and that is absolutely normal. This is required to ensure regular cooperation from the patient during the test procedure. Then we put some local anesthetic like 4% lignocaine drops with or without decongestant drops as required in patient's nostril. We do not give throat anesthesia because we do not want to interfere with the physiological swallowing of the patient. And then we prepare the food consistencies to be given. In Nightingale Hospital, we give methylene blue in water for dyed liquid, and we give biscuit mixed in milk or water, or we give cerelac powder. The patient is then positioned in the sitting position, and we place the pulse oximeter for monitoring the SpO2 and vitals, and then the scope is introduced through one of the nostrils of the patient. So after introduction to the nostril, the scope has to be positioned first just above the velum. As we can see in the picture, the scope is positioned just above the velum, and the patient is asked to do multiple dry swallows. And during the swallows, the soft palate elevation should be noted like this, so that the nasopharynx closes while the patient does the dry swallow. The next position for the scope is the home position, which is the most favorable position because it offers us the panoramic view of the pharynx and the laryngeal inlet. It also allows us to have a look at the anatomy, the secretions, the vocal fold mobility, and sensory testing can be done in this position. So in this image, the scope is positioned just above the epiglottis, and this is the panoramic view of the pharynx and the larynx that it offers to us. Now, what is phase? This is phase with sensory testing component. So that's why we were avoiding the throat anesthesia in the earlier stages. Ideally, air pulse generator is used, but since a lot of us do not have it, so what we do is gently touch the arytenoid tip with the tip of the scope that we are using and look for laryngeal adductor reflex. That is the brief involuntary closure of the vocal cords. It's important not to vigorously touch the arytenoid, otherwise the patient may go into laryngospasm. So this is a short video. Tip of the scope is just lightly touching the tip of the arytenoid, and immediately we can see the vocal cords go into a brief adduction, that is involuntary. After that, we begin the swallowing component of the examination. The patient is given different food boluses, dyed or not dyed, and the bolus should be typically less than 5 ml so as not to invite a gross aspiration, if any. First of all, the patient is fed the bolus and asked to hold the bolus in mouth for a few seconds. Now, during those few seconds, if the liquid or the food finds its way into the vallecula or piriform sinuses, it means there is some base of tongue weakness and indicates premature spillage. After that, the patient is asked to swallow and the bolus passage is noted. At the tip of the swallowing, there is a whiteout phase. We'll come to a video later on. Whiteout phase indicates that the hypolaryngal elevation has happened and it's present in normal, and it may be absent in patients where the laryngeal elevation is impaired. The scope is then further put into a position over the laryngeal inlet. Now in this position, just above the vocal cords, the scope is positioned, and it allows us to have a closer look at the laryngeal inlet and if any penetration or aspiration has happened. So what are the basic features that we can look for in a phase? So before going for the swallowing component, the anatomy of the structures, the range and symmetry of motion, whether there is any pooling of secretions, that is patient's own salivary secretions, any premature spillage of food, whether the sensory testing component is okay, whether there is whiteout phase present or not, and passage of bolus and residue. And finally, we do the penetration aspiration score if applicable. So there are some examples of anatomical findings apart from the normal anatomy that we have. The first picture is of a patient who had later diagnosed to be a patient of cricoid region growth, but he was complaining of constant coughing, and because of that, the arytenoids got swollen in the process. And that's why the region of the piriform sinuses is very much constrained, and it led to spillage of food into the laryngeal inlet. The second picture is of a post-radiotherapy patient with gross edema of the epiglottic folds, more on the right side than on the left side. The third patient came to us with choking episode, found later to have a left vocal cord growth, and the left vocal cord was fixed. And the fourth image is of a patient with post-radiotherapy edema of the epiglottis. The pooling of secretions can be found in a lot of patients. The first two images were of a post-radical neck dissection patient who had difficulty in clearing her own secretions over a time, and we can see clearly saliva is accumulating in the piriform sinuses as well as the vallecula. The third image is of a patient who had undergone radiotherapy resulting in very thick mucoid secretions which refused to leave the left PFS. So what does a normal phase with whiteout phase looks like? This is normal anatomical feature. The liquid goes in, the epiglottis enfolds, and for a split second, we are unable to see anything, and that is the whiteout phase. Premature spillage. This was a patient of a neurological deficit, base of tongue, and we can see the liquid pouring into the vallecula and into the piriform sinuses without initiation of the pharyngeal swallow up to this phase. There are some residue rating. Residue after the passage of bolus. Ideally, 5 ml bolus should be cleared by the normal swallowing of the patient, but if it is not there, then there is a residue rating system for secretions present in vallecula and piriform sinuses. So 0 is when there is no residue. 1 is when there is mild residue coating of the cavity after the swallow. 2 is moderate when there is a coating, but less than 50% of the bolus remains in the cavity after the swallow. And 3 is severe when there is more than 50% of the bolus in the cavity which remains. So the first image that we see is of a patient who had cricoid growth, and this, because of that cricopharyngeal spasm and growth, this fluid was unable to clear after multiple swallows as well. The second patient is of the patient, as I told in the before slides, is the neck dissection patient, and she had a residue after even having semi-solid food. So what is penetration now? Penetration is basically entry of the food material into the laryngeal vestibule, and it remains above the level of true vocal cords. This is a video. This is a post-radiotherapy patient. All the fluid just finds its way into the laryngeal vestibule, but the patient is quick enough to respond with a cough to clear it out before it reaches the tracheal lumen. Now, what is aspiration now? The entry of material when it reaches below the level of true vocal cord. Now, it may happen before, during, or after the swallow of the patient. This is also a post-radiotherapy patient. Now, this aspiration is dangerous. We can see there is absolutely no response from the patient to the aspiration that is happening. Absolutely no cough, and absolutely dangerous for the patient to continue with oral feeding in this case. Now, this is a scoring system that has been made in order to have a good follow-up of the patient, the penetration aspiration score. So score 1 is normal when no material enters airway. 2 is when it enters the airway, it remains above the vocal cord and is ejected from the airway. 3 is when it remains above, but it is not ejected from the airway despite effort. 4 is when it enters the airway, it contacts the cords, is ejected. 5 is again, it's not ejected despite contacting the vocal cord. From 6 onward, the aspiration is happening. It crosses the level of vocal cords. It is ejected with the patient's cough. 7, it crosses the plane of vocal cords, not ejected despite effort. And 8 is what we saw in the previous video. It is not ejected from the airway and there is absolutely no response to aspiration. This is just a format of fees report that we do in Nightingale Hospital. It basically encompasses every point that I have mentioned in the slide, along with the recommendations, if any. And what are the problems that we can expect with fees? Like any other laryngoscopy that we do, it is difficult to do in patients with cognitive impairment if they do not understand our commands. So for those patients, maybe video fluoroscopic study will be a better option to do. Also, aspiration and violent cough may happen, so we should be careful not to use the bolus more than 5 ml. Gagging and vomiting may happen because we are not using the throat anesthesia. And it's important not to let the scope touch any of the pharyngeal lumen while doing the test. Vasovagal syncope and epistaxis are rare in experienced hand. And the laryngospasm is not going to happen unless we do not touch the tip of the arytenoid vigorously while doing the sensory testing. So while in concluding remarks, FEES is a very reliable procedure for assessment of pharyngeal swallow. It allows us both to diagnose the dysphagia and also give biofeedback during the treatment course. Allows for portable examination and also can be done repeatedly in patients without the thought of radiation hazard coming in, and also vital component in evaluation and management of dysphagia. These are my references, very good books, courtesy Dr. Gugui. And thank you so much for having me here. And thank you to all my seniors for giving me this opportunity. Thank you. I'll stop sharing now.
Thank you, Priyam. Thank you. You have finished quite actually much before time, in fact. And since we have got time, we thought of addressing the questions a little later after the first endoscopy. So there's a question from Dr. S.B. Phukan sir. He wants to know in FEST, only arytenoid, touching the arytenoid is done or any other ways of doing sensory testing? You have mentioned, but would you like to expand on that?
Yes. Basically, sir, not in our scope, but in foreign countries, for some research purposes, they have a different port for letting the air pulses. They let in air pulses of different threshold, and then they see at which point the patient's the laryngeal adductor reflex goes into action. But it's not commonly seen in India. I have not seen, Menon sir probably knows about it, but I have not seen anyone using the air pulse generator to elicit the sensory testing.
Menon sir, for your comments, if something has been left behind.
We need to do that calibrated checking and all. Most people are not doing it really. And if you want, really you can actually do in your own modification. What you do is you connect a 20cc syringe to the channel of the scope and then push in air.
Okay.
Only question is that you cannot really calibrate how much force it was. So without touching the vocal cord, you can actually really test the sensation. But what I generally do is that at the end of the fees, I will actually go and do a tracheoscopy. Okay, I will go between the vocal cord. So it serves two purposes. If the patient allow without any anesthesia the passage of the scope into the trachea, it suggests that the sensation is not very great. And also you can see whether there is aspiration in the trachea. If patient doesn't allow, become coughing, and then you know that he has got excellent cough reflex. So it doesn't matter whether you fail or win, you get very good impressions. I don't think that expensive equipment is really needed.
Yeah.
Any comments from Dr. Sanjay or from Dr. Vidyadharan?
Yeah. I'll just add one point. In fact, there is a study where sensory testing by air puff and just tip of the endoscope touching the arytenoids or the laryngeal surface of the epiglottis. In fact, the touching the endoscope is more sensitive and thing. And I'm even not. I think the company has stopped the air puff thing because there was some cases of infection in the tract and thing. I'm not sure if it's available also.
I think it is not available now.
Yes.
I still touch with the endoscope only. I just follow what Dr. Jayakumar said.
I think Biswajit is ready with a patient. He will demonstrate a face procedure being done. And I would ask Priyam to actually give you a gist about and so sort of give a commentary when Biswajit is going on. And this is the case history.
The first patient is a lady, 60-year-old female, underwent total thyroidectomy. Preoperative finding was that there was a huge thyroid swelling, multinodular goiter involving both the lobes of the thyroid as well as the isthmus with retrosternal extension. And preoperatively, she was also found to have a left-sided vocal fold immobility. So the surgery was done, total thyroidectomy, bilateral recurrent laryngeal nerves were identified and preserved, while the left nerve was noted being seated inside the mass. Postoperatively, the patient had complained of recurrent bouts of cough, aggravated following food and water intake, but it subsided gradually after 1 month. In 1 month postoperative laryngoscopy, left vocal cord restricted mobility was seen with compensation by the right vocal cord. Now the patient is occasionally complaining of cough, but not so much of problem.
Yeah.
So this is an intraoperative glimpse of how the nerve was embedded in the mass and how it had to be separated.
The laryngeal branch, the esophageal branch is going posteriorly. That's what the laryngeal branch almost you can.
So I hope the video is clear.
Yes, it is clear. It's clear.
So mostly can appreciate the esophageal branch going posteriorly, and almost this laryngeal branch is inside the tumor mass actually. So what we have to do, what will be the nerve. It's almost adhered to the tumor. Though post-op it was edematous. So that's how we have skeletonized the nerve. And this was with her the post-op cough on feeding, and we did the radial. This is the most really we have the radial of now.
Yes.
So this is how we have the tumor. That's I'll clear the fast laryngoscopy. So this is the video now. Just so left quad was almost immobile, and here the she has a difficulty, particularly for the liquid. So let's see sir today. Okay. So you have to share from here. Yeah, that's
Yes, I'm here.
So let me type or let me direct me what I have to do. Okay. Consider to come here. You have to share that video. No? You go there. You go there. Let it there. Okay. You go there.
Biswajit,
Yes, sir.
Biswajit, on your left side, on your right side, don't let anybody stand. The camera has been obstructed.
Okay.
এই যে থিয় হৈ আছে তেখেতক
Okay. Now I see just on this my smoke. Okay. Okay. You just first.
So I can. You have to make me.
Oh, you have time. Co-host, no? Yeah. So you are Sochita Kalina, no?
Yes.
So I have to make you co-host. Yes, now you are co-host. Now you share. Kalakan Delhi. You go there now. You can make a full screen. You go there. I can make a full screen.
So I hope it's visible.
Yes,
yes we can see both but Biswajit's full view, can the camera be adjusted a little bit more so that people who are not used to fish can see how he's positioning himself in front of the patient?
Is this okay, sir?
Yeah, this is better. Far away but better.
Is endoscopy picture here?
Yeah, endoscopic picture is rolling.
Sorry, you are using a flexible bronchoscope, isn't it?
Yes, sir.
Yes, sir.
Have you used any decongestion in the nose?
Yes, sir.
Yes, sir.
What about spray, xylocaine spray in the throat?
No, sir.
No xylocaine spray, sir.
the valuepharyngeal competence is good of the patient. The first position that we talked about, the scope in put in. So the patient is having dry swallow and the competence is okay. And now that we can visualize the epiglottis, this is the position where we usually position the scope for doing the fees.
Okay. I should not go beyond now. Yeah.
So you can just go above the epiglottis also, sir, because the vocal cords are not very nicely visible from this point. Yes. Before we give the food, sir, yes, tell her to phonate, sir. Tell her to say.
How you see, this vocal cord movement is there.
Yes.
Yes, sir. Yes, sir. It's absolutely, yeah. I think a bit restricted, but
It's definitely improved, yeah.
yes. So first of all, liquid deke, sir, tell her to hold in the mouth. Yes, sir. Methylene blue in water.
Less than 5 ml, ba?
Less than 5 ml. A teaspoonful should be enough.
Okay. Less than 5 ml? आप मुंह में रखिएगा. Just मुंह में रखिए.
Yes, this is very important. Sometimes during the test, the patient has a tendency to put their head behind. So we should be careful because in patients where aspiration is likely, this will happen more if the patient the head is turned back.
Next step, Priyamba.
The patient is holding the liquid in the mouth.
Yes. Yes.
So since we are not seeing any liquid passing on into the valvular and pyriform sinuses, now the swallowing has happened. Yes, this is the whiteout phase that we were talking about. For a split second of second, we could not see anything at the height of the thing. No residue can be seen in the pyriform sinuses. It's absolutely okay with the liquid.
Okay. Okay. Then what to do beyond?
The semi-solid food, sir, white semi-solid food you can give now. The same amount that you gave with the liquid.
Right.
Okay, she has taken it into her mouth.
The scope forward. Scope has dragged behind. Yes, okay.
I think it's after the program. Okay.
Yes.
Okay. So absolutely okay. So now you can forward the scope just over the laryngeal inlet, sir.
Okay. Hello.
Let us swallow first. Sometimes people require 1 or 2 swallows.
Hello. Alia.
Okay.
She has swallowed.
Yes, swallow.
Okay. So tell her to swallow one more time, sir. There is something sticking to the pharyngeal walls. Impair the view now.
Just ask her to swallow one. She said, "Who you लीजिए?" हाँ.
Okay. Up young.
Okay. So please advance the scope onto the laryngeal inlet. We'll just have a look. So there is no residue in the pyriform sinuses. So tell her to phonate E. We can see the PFS better in that way. Okay. Okay.
Okay, young.
Yes, sir. You can do the sensory testing in this patient. I think she is very cooperative. You can go ahead with the sensory testing. Just lightly touch tip of one arytenoid.
189, huh?
Yes.
Okay. Which arytenoid you prefer? Right or
Touch and
left?
come back, sir.
Right or left? Right.
So anything you wish for. Okay. We'll come back,
What
sir.
you are seeing?
Okay.
Okay.
Okay, sir. Yes, sir. We are
Thank
absolutely
you.
okay. So the field finding in this patient was normal. There was no spillage. There was no penetration, no aspiration seen with 5 ml given to the patient. She has recovered most part of the left vocal cord immobility that was present, probably because of neuropraxia in the post-operative period, but now it's on the recovery phase. Almost probably 80 to 90% has been recovered by the patient. And I think she'll do good with the current food that she's having now.
Thank you, Biswajit, and thank you, Priyam, for your any comments from JKR sir about the procedure being demonstrated. Anything you would like to have added there, sir?
No, perfect. And Priya's comment, she was covering it very well. Good commentary, good indication. Yeah, but it's an interesting case. You know, it has recovered, and we saw the dissection. This was probably attached to the capsule. So in a very big thyroid, sometimes this happens. The nerve will be very, very close to the capsule. So if you open up the capsule little bit away from the nerve, you can actually peel it off. And here we have seen that has practically recovered. There is nothing much. Maybe there was slight pooling after first swallow, then it got cleared. The pharyngeal branch, the branch to the thyropharyngeus sometimes can actually get damaged in thyroid surgery too. So maybe there is some stretch injury to that also in the beginning, but I think now it has completely recovered. Very good demonstration.
Sir, Menon sir, I have a question, sir.
Thank
Suppose
you.
she had a left vocal cord palsy even now.
Yeah.
So what we usually suggest is a head turn to the left. But when do we have to add the chin down posture as well to the patient?
No, now the patient doesn't have any problem. The head turn, everything comes only when there is pooling in the pyriform fossa. Now it has recovered. So I don't think the patient require any turn or tilt as of now. Patient is swallowing through both pyriform fossa. We saw that. But with the semi-solid, there was one stagnation, but with the second swallow, that was cleared. So I don't think this patient require any specific instruction. She's on the way back to complete.
Okay, okay, thank you.
Thank you, sir. Thank you, Priyam. So now we pass on to the next stop, which is by my friend, Dr. Sanjay Subaya from Bangalore. In fact, when I was going through Sanjay's biodata, at the time I stand to realize that Dr. Sanjay and we are actually MS of the same batch, 1992, from different places, of course. Dr. Sanjay Subaya runs a voice and swallowing clinic in Bangalore. He is the visiting neurolaryngologist at Nimhans Hospital. He was an assistant professor in the KIMS Bangalore from 2000 to 2008. Before that, he was with St. Martha's Hospital from 1996 to 2000. What I've heard from Jayakumar sir is that Sanjay actually had a good ENT practice, which he suddenly decided to give up and move entirely into laryngology after getting doing his fellowship with JKR sir. And I think it's sort of like the Buddha gets enlightened. I think Sanjay got an enlightenment and gave up everything else and has now taken up laryngology, has become a full-fledged laryngologist only from the time he went as a fellow. So now Dr. Sanjay has got a lot of experience, been with the Nimhans on neurologic dysphagia. So he will give us an overview. Actually, what I was told that his talk is actually about 2 hours long, when we had to press him to curtail it to 30 minutes, which must have been quite difficult for him. So thank you. I'll ask Dr. Sanjay to get on, please. Thank you.
Thank you, sir, for the nice words. And it was also an interesting anecdote. You told me that I had an ENT practice, but actually, I attended one music. We were speaking about yesterday, sir, Dr. Jayakumar Menon's talk about singing voice. He had actually a few years back in 2012, he had conducted this exclusive one-day workshop on singing voice. So it was, they had introduction of what is the singing parameters. And then I attended that workshop. I was very much impressed. After that, I stayed back. And then after that, I came to know that he's starting a fellowship. I asked him. And then that is how my relationship with sir and laryngology started. I was impressed. So then I felt I should continue. I don't have any regrets. I'm happy that I'm doing that. I just wish I'd started a little early. So, but anyway, no problem. It's a thing. I thank the organizers for this opportunity to speak here. So broadly, we had a very nice discussion on how to start with the examination of swallowing disorders. Fees. Swallowing disorders broadly are of two types. One is neurogenic, second is head and neck cancer. I will be speaking about the neurogenic. Dr. Vidyadhar will speak about head and neck cancer. So this is an important group of neurogenic dysphagia. So basically, a neurogenic dysphagia is in anywhere in the neurogenic control of the swallowing mechanism if there is an issue. So what is swallowing? Where are we concerned? Basically is the swallowing is a mechanism where bolus is moved from the oral cavity into the esophagus. If you want to see, it starts with oral cavity closure and opening of the upper esophageal sphincter. So this complex neurovascular mechanism requires a whole lot of neurological system, the cortical, subcortical, brainstem, then the nerves and the muscles. So if there is a lesion anywhere in this chain of chain, it can lead to neurogenic dysphagia. One extra thing you have to keep in mind, neurogenic dysphagia generally is more common in the aging or the elderly people. So in which case the aging changes are also superimposed on the neurogenic dysphagia. So this is a cortical homunculus. You can see that where the swallowing control is there. So it starts from here. And then after that, this is briefly the chain. So in various disease, various parts of this system can be affected. In stroke, it can be either in the cerebral cortex, brain stem, or in the medullary. In myopathies, you can have in the muscles. Myasthenia gravis at the neuromuscular junction. In ALS, you can have either LMN, the motor neurons, or upper motor neurons. So like this, in neurogenic dysphagia, depending on the cause, anywhere along this system, it can be affected and it leads to neurogenic dysphagia. So basically now what we saw in the fees was examination was physiologically the action of 4 sphincters. This is where the most important. You see that pharynx is always a respiratory where the nasopharyngeal sphincter and the laryngeal vestibule is open. Air enters from the nose into the trachea, and the oropharyngeal and the upper esophageal sphincter is closed. And then for a fraction of a few seconds, it's converted from a respiratory into a digestive, where the nasopharyngeal and laryngeal vestibule sphincters close, and the oropharyngeal and the upper esophageal sphincter will open. And then again, within a fraction of second, it reverts back into a respiratory system. So by this, the bolus must pass into the upper esophagus. If it enters into the airway, it is a mishap. Or if it enters into the nasopharynx, it's a mishap. Or if it retains in the pharynx, it is also a mishap. So these are all the various issues which can happen. So if it passes into the trachea, it is called impaired safety. Safety is an issue. If it will not pass into the esophagus, it retains in the pharynx, it is impaired efficiency. So both impaired safety, impaired efficiency leads to oropharyngeal dysphagia. This is why we did the examination fees to know if this is there. So why is it important? Impaired safety can lead to penetration and aspirations, can lead to recurrent attacks of pneumonia, readmission, and then you might lose the patient. Impaired efficiency can lead to malnutrition, dehydration, sarcopenia, and various other changes in the body, can lead to recurrent hospitalization, and this also can lead to mortality. That is why it is very important for us to assess. And in many of the neurological diseases, the neurologic disease per se might not kill the patient, but the swallowing issues like aspiration pneumonia, malnutrition, we might lose the patient because of these causes. That is why dysphagia management is very important in neurological cases. So if the various causes of neurological dysphagia, if you look at it in the textbook, you have a whole lot of issue. And as ENT surgeons and SLPs who manage swallowing, this is not important for us. I broadly divide them into 2 categories. The first category is stroke and traumatic injuries, either a trauma or surgical, where the worst has already happened. The worst damage has already happened. It is behind us. It can only get better. And the other of neurodegenerative neuromuscular diseases, where the worst is yet to come. So in the stroke and this variety, most of the time when we see the patient is already on a nasogastric tube. So our intention is to remove the tube as early as possible. And in this other variety, our intention is to postpone insertion of tube to as late as possible. So this is broadly two types of categories under which we have to manage. And again, aging, because we have to understand aging is very important, changes which also adds to this. So neuromuscular dysphagia is basically there is no organic, like ENT surgeons, we do an endoscope, we might not see any organic pathology in most of them. And it is secondary to a disease. Many of the times when we are not diagnosing the disease by dysphagia investigation, they already a known case of Parkinson's, known case of stroke or ALS will be there. So our management simultaneously along with the root cause treatment is also there. And many of them, the root cause treatment is not available. Like Parkinson's or thing, it continuously goes on. And as the disease progresses, our dysphagia management also must alter. You can't do one management and tell bye-bye. I mean, you have to keep assessing the patient. As he gets better or he gets worse, we'll have to keep altering the thing. This is the difference between neurogenic and head and neck cancer dysphagia. So before we assess what is abnormal, we should know what is normal. Anyway, just now you saw a demonstration of a normal swallowing. The patient had a good swallow. So even in the bedside, when you go and assess, you can ask the patient to swallow some water. And then you can see that after he swallows, if he has a good voice, and if he was able to, you can ask him to cough. And if he has a good cough, he's able to bring out secretions, if any is there. And on examination, you can see the Adam's apple moving up. These are broadly, clinically, bedside, you can say that he has a normal swallow. So dysphagia management is broadly into two parts, a diagnostic phase and an evidence-based management. Diagnostic phase, we have a screening. Many of the times it will be the nurse or it can be a duty doctor. Then after that, we have a clinical assessment, which we might do as ENT or SLPs, and then instrumental evaluation. And like it's mentioned by earlier thing, cognitive ability of the patient should also be assessed. And then we have evidence-based management, rehabilitation. You might have to do drugs, surgical, and then enteral. And now the new thing is we are moving from rehabilitation to restoration. And many of the times it's a combination. A single modality will not work. So this is a flow chart, what I mentioned. You do screening. If it's negative, you can start oral intake. Positive, you keep nil per orally. And then any doubt is there, you take him to the next level. Clinical evaluation of swallowing is done. And then if it's negative, again, oral intake. And then instrumental evaluation is done. And after that, you can start your rehabilitation. Instrumental evaluation is nicely already been discussed and demonstrated. So each stage of swallowing, whenever you examine, you look for the signs and you try to elicit what is the physiological abnormality behind the sign. That is very important. You have to elicit the sign and what is the abnormality, the physiological abnormality behind the sign. That is very, very important. So these are all the various signs which we might elicit, and this is the physiological abnormality behind that sign. These are a few videos. This is video fluoroscopy to see the oral cavity. You can see that seesaw movement of the tongue is there. You can, now there is little aspiration. There was little residue. It's a case of Parkinson's. This is another case, bolus. You can see that there is little nasopharyngeal regurgitation. You can see residue is also there in the vallicula. And it's a weak, numerous attempts to swallow. You see that the swallow effort is also very weak. Then the pharyngeal stage, we have a lot of findings, and this is the important one which we see whole lot of signs and the abnormalities which might be there. Many of the signs, the abnormality itself can be a sign, and then any sign you see, you have to deduce what might be the cause or the cause for this sign. Along with that, because you have to then afterwards manage it according to that, and most of this is already discussed in the fees. Broadly, if I have to discuss what are the main abnormalities, is hyolaryngeal excursion, pharyngeal contraction, and upper esophageal opening issues. These are the main issues commonly what we see in most of the neurogenic dysphagia. So whiteout is already mentioned. I think Dr. Priyam Sharma, she spoke quite a lot about whiteout. And same thing. So whiteout is when the larynx elevates and it contracts and the larynx comes and hits the tip of the scope. So at that time you see only a whiteout. It is a sign that there is hyolaryngeal excursion, elevation. It's very important because hyolaryngeal elevation is an instigation or a stimulus for closing of the vocal folds and opening of the upper esophageal sphincter. Then a pharyngeal squeeze is a test to see the pharyngeal contraction. You ask the patient to see to do a high-pitched EE. You can see that medialization of the lateral wall of the piriform sinus. You can see that. This is very important. This is an abnormal and ALS patient with very weak pharyngeal contraction. You can see that he is doing a high phonation, but there is no medialization of the lateral wall of the pharynx. And sensation also is already discussed, and Dr. Biswajit also demonstrated this. Sensory examination is also very important. You touch the arytenoids or the laryngeal surface of the epiglottis and you look for the laryngeal adductor reflex. Then upper esophageal sphincter opening. So this is an edited video. This is vallicula, piriform sinus, little aspiration is there. You can see that this is the upper esophageal sphincter. In this case, there is an abnormality. There is a spasm of the upper esophageal sphincter. This is the aspiration. So this is how we assess. And then we see what is the problem and we deduce the abnormality. So I mentioned in impaired safety, you see penetration and aspiration. Residue you see in efficiency impairment. So you can score both of these. This is Rosenberg score, and it is known to everyone. And this is residue scoring you can do. You can score the location. You can also use percentage in residue, 0 to 25, 25 to 50, and above 50. Scoring is very important. You will know if the patient is improving or whether your treatment is helping. And even for if you have to refer to another center, you know that what were the parameters. And then after that, why we did all this testing, everything is for the $1 million question is whether to feed or not to feed. But many of the times in most of the workshops, everyone expects a single word answer to feed or not to feed. But actually it is not as simple as that. It requires, it is, a decision you take with lot of discussion and thing. So starting, you can't take an individual decision. You should have collaboration with the patient, family, and then health professionals, and also ethical issues. In many neurological cases, treatment, there is no treatment. So it is end result is known. So many of the times we have to give importance to the patient's desire, whether to have a parenteral feeding or no. So these are, it's very important. So you have to bear that in mind. And what is the intention of, what are the goals we have to see? Pulmonary safety, very important because you don't want to have aspiration. And again, impaired safety, impaired efficiency. promote nutritional integrity, very important. So if I can achieve this, it doesn't mean that every patient you do a nasogastric tube and tell lungs are safe and nutritional integrity is also achieved. No, because we have to normalize the swallowing physiology and maximize quality of life. These two safety issues we have to achieve under the parameter of, as much as possible, normalize the swallowing physiology. And earlier it was mainly we had focus was on aspiration, but now we are realizing that maintaining of overall nutrition is also as important. And if malnutrition or dehydration will later on lead to multiple complications and is an increased cause of morbidity and mortality. In neurological, in certain diseases, early intervention is recommended, like stroke and MND. And in some cases, like I said, ethical issues, when I said dementia, there is no evidence to show that tube feeding will help the patient. So we should not unnecessarily force the patient into that. And once you decide, you have to decide short term or long term. You can do nasogastric or PEG. In COVID time, nasogastric is preferred because of all, I mean, you're quite aware there is a lot of COVID. So this is, I can't discuss all the neurological diseases. In stroke, because many of the workshops, I see many people ask the question, I should feed or not feed, or a thing is always a dilemma in most of the things. So this is a nice chart. You can see if there is penetration, aspiration of saliva. So you can score it. In 5 and 6, there is no oral feed. 1 and 2, you can do oral feed. In others, in between, you can do oral feed plus nasogastric feeding, a little consistency alteration. This is a nice chart. If you can follow according to the consistency, if there is penetration or aspiration, you can plan the management accordingly. This is exclusively for stroke. Then aspiration pneumonia, the dreaded complication, what we all say. So there are some ingredients which have to be there. Minimum criteria have to be met to happen that. One is poor oral health, malnutrition, sarcopenia, immunity, and aspiration and impaired cough reflex. Jayakumar Menon sir, he said that what he does, he passes the scope into trachea. So you can know that. So if there is no cough or anything, means chances of aspiration is very high. So there has to be aspiration and there is a focus of infection up. This will lead to aspiration pneumonia. So then afterwards, once we have a diagnosis, we made the, what are all the abnormalities, then we decide on the management. So like I mentioned, oral care and nutritional support, very, very important. Many of the times we don't emphasize on this, being ENT surgeons. So we have to do this. So you can have a dentist to take care of the oral care, and frequent brushing and oral rinsing is very important. Protein energy, you have to, nutritionist support has to be taken, and we have to have good nutrition support. After that, whatever we saw, the signs and the abnormalities. For signs, we will do compensatory management. For the abnormalities, we do rehabilitation. In certain cases, like vocal cord paralysis, you can do injection laryngoplasty or thyroplasty, and medically drugs have to be indicated in Parkinson's thing. Like earlier I mentioned, a combination is there. Now the new thing is restoration of swallowing. I'll speak about that a little later. So whatever signs we do, we overcome by dietary modification and compensatory. Pathophysiology, we do rehabilitation. Both of them is important, because rehabilitation, patient will not eat immediately. Rehabilitation will take a couple of weeks. Until that, you can't ask the patient to fast. So the signs in dietary modification and compensatory measures, what we do, we tide over the immediate necessity. Pathophysiology is long term. So when you advise treatment, both you have to take care. But before I go into that, a nice word about a saying in one of the papers, I like this, that many of the times we follow the experts, we have to look for our own wisdom and evidence-based practices. So compensatory mechanism is like a bypass. A road is blocked, you are not treating the block, you are making a bypass. If you remove the bypass, the block will remain. So what you are doing, you are just bypassing the abnormality. If that compensation is removed, then it will come back to the original state. So this is one, but immediately you can start the feeding. Like in this a head posture and head rotation, this is what head rotation, Dr. Priyam was speaking for vocal cord paralysis. This is after neurosurgery, he had vocal cord paralysis. You can see that he is keeping it in the mouth, rotating the head towards the left side, and then he is swallowing. And then you can also, in neurological sensory enhancements, you can do either you can take a probe, dip it in ice cubes and massage the tonsillar pillars, or chemicals also, acid, pungency, tactile. Various modalities are available, low electrical and mechanical, some rough surface massaging. So you can try all this to improve the sensory enhancement. Then bolus modification also, where now you are modifying the bolus. You can reduce its volume, viscosity, thickness, texture. All this can be thing. They have very high level of evidence, but compliance is little bad. So rehabilitation, we see what is the abnormality. According to that, you will devise the exercises. The exercises will restore the muscle strength or the muscle thing. So this is a permanent thing. It works on the principle of neuroplasticity, and it takes a little bit, a few weeks for it to be obvious. The exercises can be swallowing exercises, which involves swallowing. It is like Virat Kohli practicing in the nets. So in this, you have effortful swallowing, Masako, Mendelssohn. These are all the various swallowing. These are exercises which involve swallowing. There is one risk, is that because they are swallowing the bolus, there might be chances of aspiration until he learns. Until the muscle completely rehabilitates, there can be instances of aspiration. You have to be a little careful of that. Then you also have another set of exercises, non-swallowing exercises. It is like Virat Kohli lifting weights. In this, it does not involve swallowing. So you can oromotor, shaker exercise, chin tuck against resistance, expiratory muscle strength. These are all various exercises which are non-swallowing but will help the swallowing. So all these exercises work on the principle of neuroplasticity. These are all the principles which use it, lose it, use it, improve it, and specificity on which it works. So there is some, many of them have effect, but actually, unfortunately, evidence is a little bit less in many of the swallowing exercises, except Mendelssohn maneuver. In non-swallowing, shakers and expiratory muscle strength, there's a lot of evidence. It doesn't mean that the other exercises does not help. I'm just telling there is no evidence based that there is no study it is there, but otherwise those exercises are good. This is only to inform you to be aware of it. Then biofeedback is very important because you have to educate the patient. Anything they want, any exercise you have to do, you have to educate the patient. This is a tongue strengthening exercise. You can keep it in the mouth and press it against the palate. You can see the numericals there. According to that, you can show him how much he is achieving strength level, and he should increase. You can also do it in the face or surface biofeedback is very, very important. Then medical and surgical, various measures depending on the type of case, myotomy, dilatation, medialization. So these are all quite injection laryngoplasty. Usually the most common surgery which is done, open fold paralysis, is also described. Sir, I have a time, or I should stop because I do not know how much I am.
Please continue. Please continue. Please continue.
Yeah. So now earlier we were with rehabilitation. Now we are going into restoration of the swallowing function, which is damaged. So what actually happens is, this is what is called cortical reorganization. So usually swallowing has got bilateral cortical representation and one side is dominant. If unfortunately the dominant side is affected in stroke or other neurological problem, this individual will have swallowing problem or dysphagia. Studies have shown that in those people in whom swallowing recovers, the non-dominant hemisphere, the other hemisphere, takes over the swallowing function and swallowing is restored. So then immediately, as soon as this study came out, then many people thought, or many studies came out when they said that if we can only enhance the non-dominant hemisphere taking over the swallowing, we can almost restore every dysphagia, neurological dysphagia, the swallowing can be restored. So like that, lot of other theories came out. So this is how was that study. This is right side. You see that left side is damaged. I think the swallowing center representation was less, but in those people in whom dysphagia was restored or who recovered from dysphagia, the swallowing center was enhanced, the thing, and it was maintained. So then immediately then people thought that if we could promote this swallowing takeover of the non-dominant hemisphere, we can restore swallowing. This is now a very the happening area in dysphagia treatment. This again, it works on the principles of neuroplasticity, where neurons are made to make new synapses, modify structures, and it's called cortical reorganization. So these are all the various studies which afterwards came and which said how to enhance cortical reorganization or how to enhance the non-dominant hemisphere. Various studies have come out. These are all the various studies. So in this, there is increasing the sensory input is one of the main things. So you can either have peripheral neuromuscular electrical stimulation, pharyngeal electrical stimulation, gustatory stimulation, and central repeated transcranial magnetic stimulation. These are all stimulate the non-dominant hemisphere to take over the swallowing function. So this is a neuromuscular electrical stimulation. In my clinic, we are using it. So each time he gets an electric current, he has to swallow. So it will send to the central nervous system the stimulation. This is a pharyngeal electrical stimulation. It is like a small endoscope, like a nasopharyngeal laryngoscope. There is a small a tube-like thing which is inserted via the nose into the pharynx. And then afterwards, in people with tracheostomy, you can't do an external neck stimulation. In those people, we use this. We stimulate the pharynx from inside the pharynx. So this is repeated transcranial magnetic stimulation. This is the machine. So this is the magnet, which is kept over the cortex. And then you can give magnetic waves, and then you can ask the patient to swallow. This is there in NIMHANS. We are using it in NIMHANS. Thank you.
Thank you, Dr. Sanjay. It was really excellent, very good, very exhaustive, and yet you have compressed it to a large extent.
Thank you, sir. Thank you.
There are some questions before I come to the comments from Jayakumar sir. There's one query from Mitali Sharma. She wants to know, she's a SLP, I think. She wants to know what is the dominant hemisphere for swallowing. Which is the
left side. In right-handed people, it's usually the left side. So that is why in right-handed people, if you have left-sided cortical stroke, swallowing might be affected. The corresponding area in the right hemisphere takes over the swallowing.
Dr. S.B. Phukan wants to know, can lingual fasciculations be due to any iatrogenic causes?
Iatrogenic causes. Yeah, lingual fasciculations is usually due to UMN type of lesion. So, I mean, I don't think any iatrogenic can cause lingual, I don't know.
I think before any more questions come up, I think then can I have comments from Jayakumar sir?
Wonderful, Sanjay. I think I am hearing this third time. Yeah, each time I actually get newer point. It's actually one of the most fascinating field now in swallowing neurodysphagia, because we are understanding the pathophysiology now. We were earlier thinking that all these things happen peripherally, but now we know that actually it is centrally it is happening. More things are happening. So that make more sense for all this stimulation, continuing dry swallow. We always tell that, you shouldn't allow the patient to just go and swallow nothing. That is going to be trouble because the neuroplasticity will be gone. So we even give something like, at least the swallowing movement has to go there. And now we have got a lot of stimulation like, transcranial, the magnetic stimulation. All these things are coming into the picture. Great. I think this is fast developing science. Maybe in the few years to come, it will become even better. One more comment, Sanjay. I think especially when you are dealing with the pharyngeal sphincter, and especially with the tongue and all, is probably
Sir, that important thing we lost. Yes. I think the important point you came to. I think, can you repeat it, sir? I think that important. We lost the important point. Can you repeat it, sir? We didn't get it.
No, what I told is that when you are talking about that, that sphincter, the pharyngeal. Yeah.
Oh, again.
Can you hear me now?
Yes, sir. Yes, sir. Yes, sir. Repeat, sir.
Talking about the neuropharyngeal dysphagia, you were talking about the sphincter, the contraction, the muscle relaxation. I think the AP view of the fluoroscopy is very, very important. I'm sure that you do that, because in lateral view, you can always see the opening of the cricopharynx, but the laterality of the weakness and the stagnation in the piriform fossa and the valliculae, for that you need the AP view.
AP view too. Pharyngeal weakness, you can see residue in one piriform sinus and the other one is the thing. Yeah. So yes, sir, agreed.
Right. Vidyadharan, anything from your side?
It was a great talk, sir. In head and neck side, we usually encounter the peripheral mechanisms for dysphagia. And neurologically, it's more complex in that sense, because you not only centrally, you have to think about not only peripheral part, you have to think about even the central part too. And you need to put two and two together. It's a lot of thinking involved. And then trying to individualize what type of treatment we can give for each patient. Yes, sir.
Hey, this question was asked me by many people, no? Which type of dysphagia is more difficult to treat?
Which type is difficult to treat?
Yeah,
which type?
Actually, the other problem is if the patient has one neurological event, sometimes they do recover, but they have repeated neurological event. And it's very difficult because each part of the brain, it gets affected, and then it's very difficult.
And the other thing is each person's recovery is different. Each part recovers different. Each person's is different. So you have to individualize. You can't say commonly put all stroke in one, all Parkinson's in one, and it's not like that. So each individualized, and many of them neurological, they have other issues, diabetes, hypertension, cardiac, and it complicates the issue even further, and you have to individualize.
And in children, it gets a little bit more complicated. For example, cerebral palsy and other neurological problems when they have. So.
There's a comment from Dr. Chaudhary Satyanarayana. He has said anticholinergic drugs can cause lingual fasciculations.
Okay.
And Dr. Phukan also wants to know any manometric help in dysphagia.
Yes, sir, it will help. It is a part of the instrumental evaluation. We can look for the pharyngeal contractions especially, and upper esophageal sphincter spasm. It's very important. Because like that, and it'll also help us whether even for the management. If you want to do esophageal, echopharyngeal myotomy, it will help if the pharyngeal contractions are adequate. If it is not adequate, your myotomy might not help much. So you will know this in manometry.
There's one query from a young person that wants to know, number one, how do you assess a non-ambulant patient? A patient who is bedridden.
Yeah. So non-ambulant, you can do a bedside flexible endoscopic evaluation of swallowing. And I showed you the chart. If you look for the secretions, if many of the times, if there is another Japanese study which says that if laryngeal sensitivity is good and there are no secretions in the larynx, there is no penetration and aspiration, in him, I wouldn't say like a blanket statement. You can try swallowing evaluation further. If sensitivity is not there and secretions are abundant in the vestibule and in the piriform sinus, then he is not a good candidate for starting swallowing evaluation. In those people, you can either teach him some exercises or sensory enhancement of the swallowing by ice cube palpation or a thing. And then you can, ice chip protocol is there, again is thing. And after a few days or weeks, you can reassess him. If the sensitivity has come back and the secretions have reduced, you can then proceed for bolus thing. Bedside, you can do a fees, no problem. In fact, fees was started as a bedside in those centers which did not have a video fluoroscopy or in whom patients who could not be shifted to a radiology department.
Do you do both in all the patients wherever possible?
No, practically it is not difficult, sir. In those in whom esophageal or oral, I try to do video fluoroscopy. If these two are not suspected, I manage with fees. But fees is mandatory for all patients. I do a fees plus video fluoroscopy if necessary.
Right. I think if Biswajit Gogoi is ready, then we can have a demonstration of a patient who has some neurological problems and have the comments from the elite panel. I don't know whether the patient is going to cooperate because there's some issue. I think they will tell you the history. Biswajit and Priyam, can you come in now?
So I'm ready. Priyam.
So we are ready with the patient.
Yeah, please tell us the history, one of you.
Yes,
Okay.
I'll just share the screen. Priyanka.
Okay. So we have a patient, a young male patient with suspected Brugada syndrome.
One second. So moving. 1 second.
Okay, so we have a 26-year-old male. He had a history of sudden syncope 5 years back, and then he was put on a prolonged ventilatory support with history of AICD, that is automatic implantable cardioverter defibrillator. And current status is that the vitals are stable, but he has motor aphasia, quadriplegia, complaints of dysphagia with drooling of saliva. When FOL was done, both the vocal folds were mobile. And the current condition is that he is able to have feeding orally, but mostly limited to semi-solid food. Difficulty is being faced with solid food.
Okay. Thank you. Priyam,
Yes, sir.
what is the Brugada syndrome actually?
So it's something to do with the cardiovascular system. So I'm not very familiar. I think this is the first time we have heard about this syndrome.
Yeah. I also didn't know about it. After you mentioned, I just Googled, and it is supposed to be a cardiac syndrome, electrophysiological, which leads to nerve impulses transmission derangement, and people are known to have syncopal attacks. I think it may be that he had a syncopal attack in which the blood supply to the central nervous system was affected, and maybe it might have caused some.
So it's an abnormality in cardiac rhythm also, sir. So our heart doesn't pump or beat as normal as possible.
And I have also not heard. Only after you mentioned it, I looked up in the thing. I am also.
The big query is whether we are going to get much cooperation from him.
Yes, sir.
First, I'm ready. Let's see.
Yes, sir. Fingers crossed.
If it's possible, I don't know.
The mother is lying inside for his support. Yes, sir. Very good.
Ready with it is not going to allow.
As you can see, there's not much of cooperation from his side. His ability to comprehend the situation.
Ready with the food.
You had to come out.
Try with the liquid.
Yeah, he's not that much of cooperative, but if you can, what thing I will if you want to go for
Priyanka, Vishwajit sir is asking, since he's not very cooperative, we'll only try once, either with the liquid or the semi-solid. What would you pick?
If you're comfortable with that, so we can do just semi-solid food.
Sir, semi-solid. Sir, semi-solid. Last time.
I think in these type of situations, Dr. Gautam sir, you were saying whether video fluoroscopy or fees. In these kind of situations where the patient's level of cognition is a little bit low, maybe video fluoroscopy would be of some help.
Right. I think Biswajit, what we can do is we can go ahead with the discussions. If you can do the scopy, you can record it. It's no point actually subjecting him to the video thing. Okay.
Yes, sir. Yes, sir.
You can just keep the recording on and try. In the meantime, we can have a discussion on going on. And if you are done with the scope, you can show us a recording. That will be much easier instead of struggling.
So yes, sir. That we can, because
I think that will be better. There is no point in showing the child who's, not a child, he's a grown-up boy now, who's struggling. Actually,
yes, sir.
He has done his engineering and then he had this attack, and the parents are very concerned about. So I was telling Biswajit the cognition is a problem. Again, that is one of the major contraindications for a piece. But still then. Sir, as Vidyadharan was saying, in this type of situations, even doing a video fluoroscopy wouldn't be so easy, isn't it, sir? Because the patient needs to swallow again. He will probably keep it in the mouth and not swallow.
But you need not pass the scope.
Yes.
So there is a point Vidya has got, because no, some days they may swallow. But let me ask, is this patient on a feeding tube now? Is he on a feeding tube now? Riles tube or peg or anything now is he having?
No, sir. No, sir.
So from whatever I could see, I just got a glimpse of the larynx and it looks fairly clear. So people who have got significant aspiration, swallowing issue, there will be plenty of. I think swallowing mechanism is all right. But as Sanjay told, this syndrome produces syncopal attacks and during one or more. So this is more like a cortical damage has happened. So it is like a cerebral palsy child, like drooling, they are not swallowing. So the frequency of swallowing has come down. Apparently his swallowing mechanism is intact, because you could get even that split second, you could get a very clear picture of the larynx. So
can I share again once more the recording?
Significant aspiration or thing, you can't see the larynx. There will be plenty of pooling.
Can you repeat again?
Hello.
Yeah,
I'm on a webinar, ma. Can you call after half an hour?
Yes. Yes, sir.
That is what I was telling. The larynx is.
Biswajit, sir wants to know what is the boy's problem now regarding swallowing. Not on any right.
Sir, parents is here. Sir, parents is here. They can send better way.
You can switch off the.
He can eat, but he can't swallow all the time this saliva. He can eat little bit. Huh.
Basically, the semi-solid, sir, not
Semi-solid.
Semi-solid.
khichdi.
Is drooling a problem, sir? Do the child?
Drooling is also issue, sir.
Yes, sir. So this constant drooling sometimes can cause coughing episodes, and we think that patient may be aspirating. But I've said Dr. Jayakumar sir he has a lot of experience in drooling patients post-neurological.
What I think is that, you know, that swallowing frequency of this young man has come is not that common. You know, the normal people will swallow at least once a minute. Now in these people, when they're damaged children or adults, their frequency of the swallowing comes down. They don't frequently swallow. The stimulation doesn't work. So it is not due to the overproduction, but due to the reduced drainage of saliva, they drool. So it's most probably the swallowing frequency is gone. And again, when Vishwajit was doing the second scopy, we could still see the larynx very clear.
No pooling.
No, the pooling of the saliva in the pyriform fossa. So that suggests that the mechanism is not very bad, but the frequency is not there. It is something like a cortical stroke. In a middle cerebral artery stroke, the patient will not have aspiration, but he simply won't swallow. They will keep it in the throat there, the swallowing frequency. I think, and with the history of he not on any tube feeding, he's surviving, he's not malnourished or anything. So that's
exactly, sir.
Bad,
Yes.
But he has got a problem with the frequency.
So in this situation with the frequency, sir, would you think a salivary duct reposition procedure would help?
Yeah, that is certainly an option because it helps in two ways. One, it reduces the swallowing. Second, by rerouting the saliva, and saliva goes and stimulate the sensitive, the facial pillar region. It may actually increase the frequency of the swallowing, and that may facilitate the eating habits too.
Because I've tried Botox in a couple of my patients, and you are also there with me in Amrita during those times. Some people it works for a few months, but then they come back. And younger children, teenagers, it affects the learning ability also.
Certainly, yeah, right. And the social stigma too.
Yeah. Dr. Vidya, while you are on Botox, where do you inject the Botox?
Sir, in the submandible gland, but Dr. Jayakumar sir also does that in the submandible gland. So we do it bilaterally.
Both submandibular glands. Directly into the gland substance?
Yes, with ultrasound guided you can do, but and we have Dr. Jayakumar sir also was there. One of the patients we have done ultrasound guided Botox injection and minimal amount of units to both sides of the gland depending on the patient's age. Parotid, no, because submandibular has the mucus secretion, and that's the one which causes all the problems. 80% of the secretion from submandibular.
Thank you, sir. Pratiksha is also here, sir. Pratiksha, you want to add anything? Also his fascia part also.
So I just wanted to ask one thing first. Does he has how is his understanding? Like if he has something or pocketing of some food inside his mouth, if we ask him just take it in or just try with your tongue, move your tongue. Does he use that?
Yes.
He used that. Okay. So and how do you find his understanding? Is like if you say, do you want to eat this? Do you want to eat that? Like can he make a choice or anything like that?
Yes, he could understand.
His finger.
He raises his finger.
Okay. So even when like when he is drooling also that time, if we ask like take your saliva inside, so he can take that, right? Like he can.
Sometimes he could, and sometimes he deny to do.
Okay, fine. So I think we can use this rehabilitation, like just asking him to swallow his saliva quite a lot of time. Maybe if he's understanding that, that's a good thing we can do. Like with a lot of even I think sir would say like if he takes a couple of swallows like for drooling, like saliva only he swallow, I think that would also enhance a lot of his swallowing capacity most probably. So
and as Dr. Sorry to interrupt, and as Dr. Sanjay sir said, oromotor stimulation also helps. That kind of gets him to swallow.
Cold probes and
sorry.
I think looks like apraxia is swallowing apraxia. So maybe stimulation will help.
I think the father was saying the tongue movement is also not adequate.
Okay.
Tongue movement is less.
Okay. So I also want to ask one more thing, like how long the rehabilitation went, like his speech and swallowing rehabilitation?
It's 3 years now.
3 years. He's continuing the rehabilitation now?
Yeah, so the physiotherapy is there. And earlier we have one speech therapy. But after near about 1.5 years continue. Then he left the class, so now it's not available in Guwahati. That is the problem for us.
Okay, okay, fine. Okay, I think he would do better, I think, with rehabilitation. A lot of rehabilitation is needed for him. I think receptive and cognitive rehabilitation is very much important for him. And then I think we can actually move on to a lot of his solving issues. That's, I haven't seen him, just from the discussion, I'm just giving my viewpoint. I don't know if I'm correct.
And actually, to add up on that, sir, you can have a treatment plan. Intense rehabilitation. I know he's been undergoing for 3 years. You can continue the rehabilitation. Along with that, you can try some medical management like glycopyrrolate to reduce the saliva secretion, and that it help with that too. If medical management does not work, then we, as a surgical point of view, we do think Botox. Botox doesn't help. Salivary diversion procedure, because I think if, as Dr. Jayakumar Menon sir said, that the larynx appears clear, piriform sinus feels clear, there's no pooling of saliva. He's not aspirating at rest, or he's not sitting there and coughing. He's good, he's normal. Only thing, the saliva accumulates and it spills over and it goes back and he has a coughing episode, or he drools down on his chest, and that becomes a bit of a social issue also. So intense rehabilitation in terms of, as Sanjay sir said, thermal stimulation, oromotor stimulation, little bit of medical management of glyco according to what you can, not completely dry him up, dry him up a little bit and see how it goes. And if it's doing well with that, then up the rehabilitation more, increase the amount, like they say, boot camp rehabilitation, keep him for 2 weeks, intense rehab. If that doesn't work, then go ahead for Botox. It's a bit of mix and match. That's what I'm saying. Individualized patient care.
I think we can actually mix it up. I think it will be better, like for him, because he has already gone, I think 6 years. He's now 26 years, and he has got it in the age of 21 years. So I think it will be always better now to actually do it medically and rehabilitation both mixed up. Then I think he'll get a much better result.
True, sir. 3 years. It is with a 3 years. Not actually.
Okay. And no episode of aspiration pneumonia during those 3 years.
Yeah.
So that's great, because he's able to tolerate at rest. It's just that drooling is a problem, and that interferes with his routine function, quality of life.
So I think Vidya has very nicely sort of summed up everything. So with Vidyadharan's Jayakumar sir, so what Vidyadharan has just summed up, I think we'll take it as the treatment plan for the young man for the time being.
Yeah. He actually told everything, including that swallowing rehabilitation.
He has comprehensively said everything.
Pharmacotherapy, surgical thing, and all these things. Yeah, that should be the plan. That should be the plan. Yeah.
Okay. Thank you, Vishnuji.
Thank you.
We'll now proceed to Vidya's. We'll proceed to Vidya's talk now.
Yeah.
Okay.
Please.
I'll just share my screen, sir.
So now we have Dr. Vidyadharan. Dr. Vidyadharan is from Chennai. He is with the Apollo Proton Cancer Hospital, and he did his master's in 2009. He had his he did his DNB as well. Then he did his MCH in head and neck surgery from the Amrita Institute of Medical Sciences in 2015. He has been an overseas registrar in otolaryngology and head and neck surgery at the Royal Adelaide Hospital in 2010. He is the fellow of the Internal College of Robotic Surgeons in 2016, and the fellow of the European Board of Otolaryngology and Head and Neck Surgery of the European Union of Medical Specialties. I have actually cut down his 2.5 page or 3 page CV to the more salient points. He has got a lot of publications, and apart from swallowing, he is a robotic, as you can see on his qualifications. He is qualified to do robotic surgery, and he has been doing that, and in the Proton Cancer Hospital. And Vidyadharan has also been he also received the Rising Star Award in Kolkata on Association of Phonosurgeons of India Manual Conference for his talk on I think he talked on swallowing, in fact, at the time. Managing dysphagia in head and neck cancers is his topic today. So, Dr. Vidyadharan, we are eager to listen to you.
Thank you, sir. Thank you for the wonderful introduction. I would also like to thank Dr. Biswadit and Dr. Priyam Sharma and the organizers of Pratiksha Academics for giving this opportunity. It's a great honor to actually present in front of my mentor and one of my close colleagues, Dr. Sanjay, whom we share a lot of ideas. So the topic I'm going to talk about is managing dysphagia and head and neck cancers. In swallowing difficulty affects almost 60 to 75% of the patients who are having head and neck cancer or treated for head and neck cancer. And each type of cancer treatment results in some form of dysphagia. And the type or severity of dysphagia depends upon the size and the location of the original tumor and all the structures involved by the tumor and the treatment modality. So many factors taken into consideration. And at the outset, this field of deglutology or swallowing is very, very, very interesting, because if you take any subspecialty of swallowing itself, whether neurological dysphagia, head and neck cancer related, or pediatric or geriatric type dysphagia, we're discussing the same structures, but with a different point of view or a different mindset, and trying to look at the same structure based on a different type of problem. So that makes things very interesting. And once the problems are all intermingled, as with head and neck cancer and neurology, things become more complicated. So there's a lot of research need to be done in this particular field or a subspecialty of ENT and speech and language pathology. So without further ado, I'll start the presentation. This is where I work. It's at the Apollo Proton Cancer Center in Chennai. We have a nice team with my senior consultant, Dr. Naveen Hedne. I've also worked at the Royal Adelaide and the Amrita Institute. And the slides and the pictures from my talk are from my work done at all these three institutes, and some are from the internet. And this is the team which I worked for quite a long time at the Amrita Institute. I'm still an adjunct faculty there. Ms. Arya is currently the clinical lead speech and language pathologist, a swallowing specialist over there. And of course, Professor Jayakumar Menon was one of my mentors. So the contents of my talk, I know the previous speakers have already beautifully described some of the side headings or titles, subtitles of the talk. So it makes my job much more easier. So I will quickly go through that in a head and neck cancer point of view. So these are the contents: physiology of swallowing, effects of the tumor on the swallowing mechanism, assessment of dysphagia in a head and neck cancer patient, effect of the radiation treatment swallowing mechanism. I want you to pay a lot of attention on that. And the importance of manual lymphatic drainage. This is another new ongoing research topic. Swallowing rehabilitation for head and neck cancer, an effect of surgery on swallowing, and a brief introduction of phago surgery, which is coined by Dr. Jayakumar Menon in India. And we're working on a new subset of that called oncophago surgery. So physiology of swallowing, as the previous speaker mentioned, there are totally three phases: the oral phase, which is voluntary; the pharyngeal phase is involuntary; and the esophageal stage, which is also involuntary. The oral phase has two types. It has the oral preparatory phase, and then the masticatory phase, and the propulsive phase. And the most important phase or stage of swallowing is the oropharyngeal or pharyngeal stage, and hence the name oropharyngeal dysphagia. And we have problems with that. Now consider the act of swallowing based on this particular diagram, because swallowing is a complex process and it requires precise coordination of 25 pairs of muscles within the oral cavity, pharynx, larynx, and esophagus. And the neural control of swallowing has been beautifully explained by Dr. Sanjay Subbaiah. So when we consider the act of swallowing as per this diagram, you find there are basically a series of valves, around 6 valves. And the first step is to identify where is the dysfunction on which valve, or which area is the dysfunction. The problem can arise with either an individual valve or failure of the valve to interact with each other in a timely manner. So one valve closes, other valve opens. And this is all about in terms of head and neck swallowing, head and neck dysphagia. Now, a few important points with regard to swallowing as such in head and neck. We have these valves which I explained. Laryngeal, the larynx itself has 3 layers of protection: the true cord, the false cords, and the epiglottis. It closes from bottom up, and you can also see the base of tongue contacting the posterior pharyngeal wall. And these two are important points to keep in mind in physiology when you're evaluating a head and neck cancer patient. The base of tongue contact to the posterior pharyngeal wall, and the airway protection provided by the larynx. And you can see over here. The second important point, as Dr. Sanjay had mentioned, is a hyolaryngeal elevation. This is the elevation of the larynx towards the base of tongue, where the anterior portion of the larynx gets tucked under the base of tongue to prevent aspiration of food into the larynx. And if patients have very good hyolaryngeal elevation, you will be able to rehabilitate them much better. And this is mainly by the function of the suprahyoid muscles. So the standard management of head and neck cancer is you can classify it into 2 types, either the early stage or the advanced stage. Most of the early stage cancers are deemed curable, and they are usually a single modality. So they could either be a surgery as a single treatment modality or radiotherapy, whereas advanced stage are combined modality. It's either surgery followed by radiotherapy with chemotherapy, or radiotherapy and chemotherapy followed by salvage surgery in case there's residual tumor. So along with our search for better cure rates, we have evolved to focus on the quality of cure now. And that's where comes quality of life, importance of quality of life, and that's where comes dysphagia management. All cancers respect anatomical boundaries until its late biological stage. So here you can see the different head and neck cancer sites, starting from the skull base or the nasopharynx, then the nasal cavity, the oral cavity, the pharynx as such, which is the nasopharynx, oropharynx, and hypopharynx, larynx, thyroid, trachea, and cervical esophagus. So we have so many different subsites, and as I said, all cancers respect these anatomical boundaries until its early stage. So early stage cancer can be just limited to one site or subsite of the head and neck, whereas advanced stage will extend to multiple subsites. And dysphagia rehabilitation has to be personalized to treat each individual patient. So each patient, the tumor is not the same. And there's a lot of critical structures very tightly packed in the head and neck region. So, they can, a small, very slight difference in the location of tumor can make a lot of big functional challenges for the patient. And most of the time in India, most of the Indian patients present with advanced stage cancer. So they have more than one subsite involvement. So coming to pathophysiology of the tumor or the tumor growth pattern, you can classify it into 2 types, either intrinsic type of tumor or an extrinsic type of tumor. Intrinsic type of tumor causes a little bit of exophytic. It will cause obstruction, distortion, or decreased sensation. If it is infiltrated, that means going deeper into tissues, it can cause fixation of the structure, for example, the tongue, cause severe pain, trismus, and cranial nerve deficits. If it's an extrinsic type of tumor, it ends up compressing and causing obstruction, for example, a large thyroid tumor or a tracheal tumor. So when you see a tumor, this is what I do. When I see the tumor in the clinic, a patient with a tumor in the clinic, when I identify the site, I start thinking, what are the mechanisms it's going to affect in the normal swallowing. And most of our head and neck cancer patients present with these array of signs and symptoms, ranging from difficulty in swallowing to coughing or choking sensation to food sticking there, and almost everybody has some amount of weight loss. We do a clinical evaluation in the form of medical history, feeding history, as has been elucidated by the previous speakers, and do some bedside swallowing tests, like water swallow test. In these patients, comorbidity is also important. There is previous history of diabetes or previous history of a cerebrovascular accident or a history of epilepsy. All these help us to give us more information on how to manage this patient in the post treatment stage. Yeah, we also do a cranial nerve assessment and also cervical auscultation as a baseline. Coming to instrumental evaluation of swallowing, as I again mentioned by the previous speakers, we do either fiber optic endoscopic evaluation of swallowing, where you can directly see this luminal anatomy, and you can actually understand how the food is passing through, and you can see that the opening of the upper esophageal sphincter. But the only problem is we cannot visualize the oral face, and in this particular procedure, we use most of the time we use real food. Whereas in video fluoroscopy or modified barium swallow, it's called the gold. It's actually considered as a gold standard for swallowing evaluation. It's non-invasive, but you do need a fluoroscopy unit. And as mentioned by the previous discussion, we need to shift the patient. So logistics is an issue. Radiation exposure is an issue. But in our head and neck cancer patients, especially adults, they've already received radiation, so it's not a big deal. And we do have to use radio opaque contrast to see. Other investigations can be pH monitoring, manometry, transnasal esophagoscopy, technetium scintigraphy for microaspirations. But the workhorse is mainly FEES and video fluoroscopy. We do use the penetration aspiration scale to assess if the patient is at risk of aspirating. And if the patient is on some tube feeding, we also use the FOIS scale or the functional oral intake scale to assess how much, what type of oral intake the patient can have. There are various different types of dysphagia grading if you actually look into literature, but they currently use dysphagia grading is the digest score, and that is the full form is dynamic imaging grade of swallowing toxicity score. It's subdivided into mild, moderate, severe, and life-threatening, and it's based on the penetration aspiration scale and the bolus or pharyngeal residue scale. So you combine both, looking at the safety and the efficiency grade, and give them a particular scoring. Now, coming to treatment, if the head and neck cancer patient has to undergo radiation therapy as a primary modality treatment, we have to know about the dysphagia aspiration related structures. So what are the dysphagia or DAS structures? What are the DAS structures? They are superior, middle, and inferior constrictor muscles, the glottis, the supraglottic larynx, base of tongue, and trichopharyngeus and upper esophagus. So how much, we need to know how much of radiation dose that these structures are going to be receiving, because if in literature there's a varied literature on different types of dose for either a primary modality radiation treatment or adjuvant treatment. It ranges from anything from 60 gray to 72 grays. And if these structures are end up having quite a lot of radiation dose, then they would have be dysfunctional after treatment. So then patient will have more severe dysphagia. So the common complications or common symptoms patient come after radiation with or without chemotherapy is mucositis, xerostomia, any sensory changes in taste and smell, severe fibrosis, which also includes trismus, difficulty in opening the jaw, loss of appetite due to chemotherapy, and also lymphedema, facial lymphedema. We have to understand more about radiation treatment effect on dysphagia. We have to understand the pathophysiology of radiation-associated dysphagia. Initial stage of radiation, patient has, in the acute stage, patient has some mucositis and edema, as you can see here. Whereas as the days go on after radiation, fibrosis starts setting in, especially in the submucosal layers, which stiffens the structures in the aerodigestive tract and causes more difficulty in efficient movement of propulsion of the food. And in the later stages, along with the fibrosis, you'll also get sensory denervation. And that makes the patient a bit of a swallowing cripple. So we have to know if the patient is going to undergo radiation, we have to know how much dose these DAR structures are going to get, and also how severe these patients are having the reactions to the radiation therapy. The severity of dysphagia depends on the extent of the DAR structures affected. So if you see a normal video fluoroscopy, this is a normal swallow in a video fluoroscopy in a lateral view, you can see there's good tongue movement, there is good palatal movement, and there is good hyolaryngeal elevation. And in FEES, if you read, you'll see a very good pharyngeal contraction, all the constrictor muscles coming together. That's what we see, the whiteout, where you cannot see the screen at all. Whereas when the patient undergoes chemoradiation, there would be, because of either disuse atrophy or because of restricted of movement due to the fibrosis, there will be decreased movement of the base of tongue towards the posterior pharyngeal wall, reduced laryngeal elevation, sometimes reduced laryngeal vestibular closure because there could be some fibrosis of the cricoarytenoid joint. There could be reduced pharyngeal construction, so you will not have you will have an incomplete whiteout. You will not have a complete whiteout, and there will be longer pharyngeal delay time. This will relate to a lot of food residue being deposited in the throat after the swallow. In some patients, they also have delay in initiation and also incomplete esophageal sphincter opening. What we don't want to, what we need to actually identify are these kind of findings. Either a silent aspiration, you can see on the left-hand side of the screen where the patient actually aspirated his contrast, and you can see it lining the trachea, and the patient is not coughed at all. He's just silently swallowing, and this is a very high risk of aspiration pneumonia leading to death. And second is the secondary aspiration, where you can see there is some amount of stricture or severe fibrosis at this junction, and you can also see an early cricopharyngeal spasm. So this, what happens is the food bolus gets held up at the cricopharyngeal sphincter level, and then it flows over onto the into the laryngeal inlet. So I would call these patients as pharyngeal cripple because they've had the tumor treated by the head cancer treatment, but they're still not been decannulated of the Ryle's tube. They're still dependent on tube feeding, and sometimes with the late fibrosis setting in, no amount of rehabilitation can actually help them to get back to at least a near-normal swallow. What we want to avoid is posterior cricoarytenoid myolysis. If the patient is basically long-term dependent on the Ryle's tube or the nasogastric tube, the pressure on the Ryle's by the Ryle's tube and nasogastric can cause indentation of the posterior part of the cricoid cartilage and cause a prolonged non-healing ulcer and also exposure of the cartilage. Sometimes constant inflammation can also cause cricoarytenoid joint fixity, and then the patient ends up becoming having a dysfunctional larynx, and then end up having a laryngectomy, and his quality of life is even worse or affected. Another factor is of recent interest is the lymphatic drainage pathway. Not only in head and neck cancer, not only we treat the primary cancer site, we also treat the lymphatic drainage site or the first echelon lymph nodes of that particular tumor. And so whether it be surgery or radiation, we end up treating the neck. And after treatment, patient will have there are totally 3 lymphatic channels or pathways. There's the anterior, lateral, and posterior pathway. And usually in head and neck cancer treatment, the anterior and lateral pathways get affected, and hence the patient will end up having severe neck lymphedema, as you can see in this picture over here. So the various studies in the literature and various classifications staging the external lymphedema, and this is what we call external lymphedema because you can see the whole face and the neck being swollen, and it's more prominent early in the morning, and patient will complain that he's feeling the stiffness in the morning and he cannot eat. And as the day goes by, the lymphedema reduces as he keeps walking around. The other important factor is internal lymphedema. Not only there is lymph fluid channels affected below the skin, subdermally, in the anterior and lateral neck, within the mucosa or around the pharynx and larynx, there could be lymph edema collection. And as you can see here, and there is also a separate grading for that too. So this can cause, again, restriction of movement of these structures, and also fibrosis setting in, and later on late radiation associated dysphagia changes such as deinnervation. So there are a lot of studies focusing on reducing the internal lymphedema, and one of the common ways of doing is what we call like how they have manual lymphatic drainage for the patients who undergone breast cancer treatment. They also have manual lymphatic drainage treatment or rehabilitation for patients with neck lymphedema. And there are studies saying that if they reduce the neck lymphedema, both external and internally, patients have better quality of life with regard to their swallowing. A small note on the statistics. Primary tumors of the oropharynx, about 31% develop chronic aspiration after treatment. About 11 patients develop aspiration pneumonia, and 4 patients are chronically feeding tube dependent after the treatment. So you can see the extent of damage even the treatment does. Not only does it take care to cancer, but it also causes damage to the normal structures. So we need to be well aware of that, and we need to really push for rehabilitation in these type of patients. So as Dr. Sanjay sir has mentioned, management of dysphagia rehabilitation is of 2 types. It could be rehabilitative, which is indirect swallowing therapy, or compensatory, which is direct swallowing therapy. Indirect or rehabilitative swallowing therapy is designed to strengthen the function of the affected muscles. So where no food is given, we just make sure that we give enough exercises to improve the stamina and the strengthen the affected muscles to increase the bulk and help them to get working. So there are 2 types of exercises. You have non-swallow exercises, which are aimed to strengthen the isolated muscles used in swallowing, such as tongue or the lateral pharyngeal wall. And then they have swallowing exercises, which aim to strengthen all the muscles used in swallowing, like, for example, pharyngeal squeeze or effortful swallow. Whereas if we take direct swallowing or compensatory swallowing therapy, we basically do adjustments to bypass the dysfunction. And over here, we can try food, and the food can be like, we can change the texture or temperature of the food that is given. We can change the posture and also the frequency of the feeds. So most of our patients need a mixture of indirect and direct swallow therapy at different time periods. In fact, the discussion, the first case where for a post-thyroidectomy, if the patient still had a swallowing dysfunction, head turn is a type of direct swallowing therapy, where you're changing the posture and giving food and saying things. And feedback is very important in these situations, both for the rehabilitationist and the patient. So with regard to changing the consistency of food, there is a standard called the International Dysphagia Standardization Initiative, where it is you work your way up from thin food consistency to a regular food consistency, and this way you can grade the patient and give them a feedback of which level or which kind of consistency they can take. The role of electrical neuromuscular stimulation, I'll come a little bit later to this. The use of this in head and neck cancer patients is debatable in literature. There are different studies for it, and there are different studies against it. But basically, in my experience, for our Indian patients, if they undergo radiation treatment, we cannot put these leads on the neck, especially in the initial stage, because they will have a severe burning when you put any of the these plaster leads on them and try to peel it off, because the skin is very, very, very delicate. And at the later stage, there is so much fibrosis setting in that this stimulation doesn't work. So rather, we need to give electrical neuromuscular stimulation or these kind of stimulation during the treatment or before the cancer treatment to improve the ability to swallow. So coming to the effect, and I've spoken to you a lot about effects of radiation on swallowing. I will talk now about effects of surgery on the swallowing mechanism. I've categorized it into different subsites, and what procedure or what surgery can do to affect swallowing and how to overcome it. When you take up for the lips and buccal mucosa, if the cancer involves lips or buccal mucosa, during the resection of the tumor, sometimes the marginal mandibular nerve can be sectioned, or when we're doing a cheek flap, that is, we're opening up the cheek to get to the tumor, there could be, when you're not reapproximated the orbicularis oris muscle after it's been transected properly, patient can have loss of oral sphincter integrity. So this will lead to anterior spillage, as you can see in the fluoroscopy over here. There is a spillage of, as the patient tries to swallow, there's a little bit of leak because patient does not have very good lip seal. And sometimes when the mental nerve is transected, as in terms of a segmental mandibulectomy, then patient will not have sensation of that part of the lip. So in that situation, we try to use some form of compensatory therapy, some form of rehab therapy, where we try to strengthen the existing orbicularis oris muscle by this particular maneuver called the button pull maneuver, where we can put the button into the gingiva, between the gingival-labial sulcus and the teeth, and try to pull it against resistance. And this is kind of trying to strengthen the orbicularis oris muscle. If that doesn't work, or if the patient has, as in this particular patient, it's an unusual thing. He's had a cancer of the upper lip with a huge resection, and you can see a huge defect, and it's been reconstructed with a skin flap, with a forehead flap. They've taken the forehead, part of the skin of the forehead, and reconstructed. But he has macrostomia, and you can see him drooling saliva over here because the flap was a bit too big. But initially we do that, the flap was a bit too big, and it is not giving a good lip seal. So we went in, did commissuroplasty, and that helped to reduce the size of the circumference of the lip, and he was able to control and drink liquids, and there's no dribbling. Because a patient like this, even though he's had the surgery, all the treatment, this is still a bit of a social stigma for him. He cannot go out, eat in public, he cannot sit in a bus, and people keep looking at him. Nowadays it's different because you have a mask to cover your face, but generally, this is a social nuisance. And I will be talking about oncophagus a bit later. With regard to tongue, there are many, we either do a partial glossectomy, which is removing a portion of the tongue, or a hemiglossectomy, which is more than removing the 2/3, at least half of the tongue. Or we do a total glossectomy, where we take off almost the whole tongue and leaving only a small remnant of the base of tongue. So patients with partial glossectomy, if the defect is less than 2/3, as in this picture over here on the right side, upper right, they don't have much of a swallowing issue. Initially, they may have for a few weeks, but they tend to adapt and overcome that, and they don't have much dysphagia. Whereas a patient with total glossectomy, there's loss of this ability to propel the bolus posteriorly, and patient would be have a high chance of aspirating or having residue in the mouth. And along with that, patient has to undergo radiation because they have advanced tumor stage. That makes things more difficult because there will be additionally neck fibrosis too. So you can see over here, these kind of patients who have tongue cancers, they have inadequate tongue control. They're not able to chew properly because they're not able to use the tongue to put the food in between the teeth to chew and then clear the food posteriorly. There's a delay in oral transit. There's always some oral residue or pharyngeal residue, and there is inadequate laryngeal elevation and large retrolingual space. So I'll show you in the fluoroscopy picture over here. The one on top is actually a normal swallow. You can see how beautifully the barium goes down. A little bit of residue, but one more swallow and that. But over here, patients had a glossectomy and not a very good adequate reconstruction. So all the residue is still stagnating here, and it just exactly goes into his larynx. And you can see the large retrolingual space, the space between the back of the tongue and the posterior pharyngeal wall. Normally, it should be around less than 1 centimeter or maximum less than 1.5 centimeter. If there's a large retrolingual space, as you can see in the fluoroscopy here, patient have a high chance of aspiration, and he will not be able to decannulate him off his tracheostomy tube. Coming to flora of mouth, the tongue is usually, the genioglossus muscle is usually attached to the floor of the mouth, and it's one of the most important muscle in maintaining the tone of the tongue and also helping with the propulsion of the tongue. So when we take off the floor of the mouth, along with the mandible, there will be limited mobility of the anterior tongue. The anterior tongue gets tethered down and stuck to the floor of the mouth. And sometimes when we take off the anterior part of the mandible, you get a deformity, what we call is anti-gump deformity, where there is literally no mandible there, and the tongue ends up falling backwards, and patient has a very, very severe dysphagia. In case if there's a mucosal resection, just the mucosa and the muscle of the floor of the mouth is removed and reconstructed, and the patient is not able to clear this residue in the anterior part, we can suggest a head back maneuver, which is a type of compensatory maneuver, where patient can tilt the head back and then swallow. This, by using gravity, you can actually swallow the food bolus. Surgery, when we're planning for the surgery, if we know that we're going to take out quite a lot of floor of mouth, and when you're doing reconstruction, we can do a hyoidopexy or a hyoid suspension, where we can, it is similar to one of the sleep apnea surgeries, where you narrow the gap between the larynx and superior part of the larynx and the lower part of the mandible. You suspend the, you put suspension sutures between the newly reconstructed lower jaw, the larynx, and sometimes the hyoid bone if it's intact. In some situations, total glossectomy, we even take out the hyoid bone, part of the hyoid bone, sorry. And here you can see a patient with a very good swallow after very good hyoidopexy, hyoid suspension, and you can see very good laryngeal elevation. And this is what I was telling in the beginning, the physiology. Good hyolaryngeal elevation helps to protect the anterior part of the larynx and open up the cricopharyngeal sphincter. At the Amrita Institute, where I was previously working, we also tried functional reconstruction, where we use a couple of different types of flaps to recreate the normal propulsive movement, or at least the contraction movement of the tongue. And you can see in this patient who's had no tongue, but we've used two types of flaps and connected that, motorized that particular flap to the hypoglossal nerve, and got this patient to swallow. And you can see the importance of hyolaryngeal elevation here. And this is the neo tongue of the patient. Patient actually is still living, and it's 10 years post his treatment. When a patient has mandibulectomy, when the tumor involves the mandible, and we have to resect that part of the mandible, there is loss of teeth, or there's malocclusion of the remaining mandible to the upper jaw. There is altered oral sphincter because that part of the buccal mucosa or the lip would collapse inward. And there is limitation of cricopharyngeal muscle opening because the hyolaryngeal complex is disrupted. So patients with segmental mandibulectomy or total or any type of segmental mandibulectomy will be more affected than patients having marginal mandibulectomy. So it's important to read the operative notes to know what kind of surgery the patient has had and how you can tailor your rehabilitation maneuvers to it. So in terms of marginal mandibulectomy, they won't have much of a swallowing issue. Just sometimes if it's anterior lower mandible, anterior part of the mandible, they will have some drooling of saliva because they cannot have a good lip seal. Whereas if you're taken off whole of the anterior segment of the mandible, they will get this anti-gump deformity, and the patient will not be able to propel his tongue back, and the tongue will be falling back, and he will have to be tracheostomy dependent. This is a picture of a patient who's undergone a segmental mandibulectomy, reconstructed with a bone flap or a fibula flap, and they've also put teeth. And for initially, the patient will have some difficulty in swallowing or clearing the bolus on this side of the mouth, on the operated side, because there's no functioning muscle there. It's just skin and bone. So we can suggest them to do this head tilt maneuver, which is a compensatory maneuver. We tell them to do a head tilt to one side, usually to the opposite side of the treated area. And that helps clear the bolus. In situations of hard palate resection or maxillar resection, prosthodontists and prosthetics play a very big role in helping with our dysphagia rehabilitation. We do have different types of prostheses. There's a palatal prosthesis and also oropharyngeal prosthesis, which help to separate the compartment of the nasal cavity from the oral cavity. Some patients when the tumor involves the deep buccal mucosa and the infratemporal fossa, they would undergo surgery and radiation, and they would have trismus, severe trismus or limited mouth opening post-treatment. And with those patients, we need to commence rehabilitation early, as in terms of jaw opening exercises and jaw opening there are different instruments to use to help open the jaw, and we need to commence rehabilitation early. In very severe cases, we can do what we call a coronoidectomy, where we cut the coronoid process, and that releases the temporalis muscle from the mandible and gives some amount of good mouth opening. In northern parts of India, patients who have habit of chewing a pan or gutka, this is a very common finding. It's called oral submucous fibrosis, where you can see linear fibrous bands along the oral cavity, and this tenses the mucosa and prevents opening of the muscles, opening of the mouth, thus causing severe trismus. And in that situation, we can resect. The patient sometimes undergoes resection of these fibrous bands and has another flap to help with the mouth opening. And all these help with the oral phase of swallowing, because patient cannot open his mouth, chew, and propel the food backwards. Coming to oropharynx, previously, traditionally, the conventional approach to oropharyngeal cancer was a mandibulotomy approach, where they open the jaw like a book and go all the way to remove a tonsillar tumor or a base of tongue tumor. But now, with the advent of the robot, we can directly go into the mouth, and we can resect the tumor, core out the tumor without splitting the mandible, and then reconstructing that part of the base of tongue. The advantage of that is that you don't violate the suprahyoid muscles, which help in hyolaryngeal elevation, and you don't violate you don't distract the genioglossus from the mandible, disconnect the genioglossus muscle from the mandible, and you're keeping all the pharyngeal muscles intact. For each structure of the tongue base, there are different problems you see. If it's a tonsillar cancer and treated for tonsillar cancer, they have decreased mobility of the lateral pharyngeal wall. For tongue base, there could be atrophy of the tongue base, and there's loss of sensation. For soft palate, there's a lot of loss of oropharyngeal suction pump, and patient can also have velar pharyngeal insufficiency. And for these kind of patients, we try different types of maneuver. One is the tongue hold maneuver, where we advise a patient to try to hold his tongue between the teeth and try to swallow. And this helps to strengthen the base of the tongue, and that helps to reduce that retrolingual space, which I was talking about. The other is the Mendelssohn maneuver, where you physically hold the laryngeal cartilage and push it up, and then hold it like that, and then try to swallow, as you can see in the video over here. It's the patient trying to hold this laryngeal cartilage, push it up, hold it like that, swallow, and then release. So what this happens is it mimics that hyolaryngeal movement and helps to open up the cricopharyngeal muscle. Another exercise is lingual protrusion against resistance. This is to strengthen the whole of the oropharynx, including the tongue base, the lateral oropharyngeal wall, and the postopharyngeal wall. Basically, we use an ice cream stick or a spoon. You can try a spoon and try to push the spoon or the ice cream stick away from your tongue, and you try to use as much resistance to do that. You can also do the Masako maneuver, which is nothing but just trying to try to push your tongue and try to stretch it out as long as possible. So all these rehabilitation exercises needs to be repeated again and again, and you don't need food. You can just use dry swallow, that is just saliva, and patient needs to practice this to overcome the swallowing dysfunction. If the patient does have a velar pharyngeal insufficiency, they can try a nose pinch maneuver, where they occlude the nose and then close the nostrils and then try to swallow. This prevents the regurgitation of the food through the nose. Now that this is it's a bit of a issue in public, because the patient cannot be pinching the nose every time they eat. So one way of strengthening the muscles of the soft palate is to ask the patient to blow a balloon, and this provides a resistance, and they can keep practicing that again to strengthen those muscles. For the lateral pharyngeal wall muscles, we can do the effortful swallow, where you really try to squeeze the take a gulp and really try to push the food bolus down, and it's effective swallow. You're trying to consciously try to use all your muscles to swallow. The other is the Shakir exercises, which basically you lie flat and just elevate your head off the bed and just try to see the tip of the nose and hold that position for a while. This helps in strengthening the strap muscles of the neck and helps with the better hyolaryngeal movement. A speech and language pathologist in Singapore, Mr. Lam, has modified this and the Shakir exercises, and is propagating a chin tuck against resistant exercise, where you actually use a ball, a compressible ball, which provides some amount of resistance to strengthen the anterior neck muscles, and do the same thing. These are many other gadgets showing the same chin tuck against resistance. Different types of gadgets are there to practice. Coming to larynx, if there is a small tumor in the larynx, patient would either have undergone a radiation treatment, or sometimes they have some type of partial laryngectomy, which is not now routinely done. But with the advent of minimally invasive surgery, these partial laryngeal surgeries are coming back in vogue. So previously, there are two types, either supraglottic laryngectomy or horizontal partial laryngectomy, which involves removing the epiglottis, the aryepiglottic fold, or the false cords, and just leaving the true cords. And this is for tumors which are not involving the true cords at all. The other was a hemilaryngectomy, or vertical partial, where the tumor is limited to just one true vocal cord, and that part is taken out. So you can see in the picture here is an example of horizontal partial laryngectomy, where the upper part of the thyroid laryngeal cartilage and all the supraglottic larynx is removed, leaving only the true cord. Now, in this situation, I was telling you about the 3 levels of protection of the larynx. 2 of them are gone. So the patient has to depend only on the true vocal cord as a sphincter to prevent any food from going down his trachea. It's an example of a case. We had a 25-year-old male who had a tumor of his right vocal cord. He had a microlaryngeal surgery where the tumor was resected. You can see in the CT scan picture, you can see the tumor on the right side, and the same over here. And you can see the tumor involving glottis and a paraglottic space. He had the microlaryngeal surgery, and he had a residual disease come back after a month, for which he had undergone a tracheostomy and then a biopsy to confirm the tumor. Then he was referred for radiation. So at the 25 years, he's had all these. He had surgery, 2 surgeries, and radiotherapy. And after radiotherapy, he still had some residual disease, which is just coming back, which is still there. So what we did was a vertical partial hemilaryngectomy, and which involves removal of 1 false vocal cord, the ventricle, and the true vocal cord on the same side. So we opened up, took off that part of the hemilarynx, and this defect was basically closed with the strap muscles of his neck. And this is the post-operative video, as you can see here. I'm just trying to get a good view of that. Yeah. Okay. So for these patients, we have to individualize these patients again, because these type of surgery is not done unless the patient is young, well motivated, and also has a very good lung function. Because if the patient is very old and is unable to do a very good rehabilitation exercise, they will be really crippled with this type of treatment, and they would need to be dependent on some tube and tracheostomy. So preemptively, we teach these patients supraglottic swallow and ask them to continue this after the treatment of also. And supraglottic swallow is basically to take the liquid bolus and hold your breath and then try to swallow and then cough after swallow. Whereas supraglottic swallow is a maneuver where you take the food bolus in the mouth, hold the breath, swallow, you bear down, swallow, and then cough after swallow. So both these two maneuvers, elderly people do supraglottic swallow, they understand much better. But younger people, they can do supraglottic swallow well. Elderly people can understand supraglottic swallow much better. So both these maneuvers help in approximating the vocal cords together, or trying to get that functioning vocal cord to come to the middle or medialize the vocal cord. And that way you're able to, physically try to close the laryngeal inlet and prevent food from getting aspirated. But beyond this, to undergo these type of vertical partial surgery, the patient should be young, motivated, and have a good pulmonary function. So a lot of factors are have to be thought of even before we plan treatment. So the rehabilitation is, be the laryngologist or the speech language should be there during the planning of the procedure itself and give their input. Hypopharynx, most of the time the treatment is radiation therapy. In advanced stage, patient might undergo total laryngectomy and total pharyngectomy. But most of the time, after radiation treatment, patient would have scarring of the lateral pharyngeal wall, or sometimes denervation of the superior laryngeal nerve, causing loss of sensation of the supraglottic larynx. And if they have a post-cricoid carcinoma, it will be high chance of stricture, and we need to be aware of that too prior to treatment, so that we can teach them the right exercises to help to minimize the onset of stricture. And that same goes for posterior pharyngeal wall. Any small tumor in posterior pharyngeal wall, the scarring can be having a lot of contraction at that area, causing a lot of dysphagia. So no point putting a nice adynamic flap there, because patient will not feel anything. So in these subsites, radiation is a better treatment modality as compared to surgery for early tumors, and thereby we can also go in and rehabilitate these patients and get them off the tubes. So where they do have a problem with one particular side of the larynx, we try the head turn maneuver, as it was discussed before, and also the chin tuck maneuver. This helps to open up the tricopharyngeal sphincter, where the patient puts his chin down and has a good swallow. Shaker exercise and Mendelssohn's maneuver also can be tried to globally strengthen the pharyngeal muscles. Coming to total laryngectomy, patients, generally the thought process is when a patient has had total laryngectomy, he's got a nice tube, pharyngeal tube, so he won't have any dysphagia. But patients with total laryngectomy also have dysphagia, because that particular neopharynx is actually the upper part is adynamic, because during the surgery, patient has had a tricopharyngeal myotomy there. So the lower resting pressure over there is, the resting pressure in that area is much less. So they will not be able to completely clear, and there is no peristalsis, and there's a normal negative or suction pressure which comes just before the bolus when you see in the video fluoroscopy is also absent. So they will have some amount of problem with pharyngeal clearance, and you need to be aware of these patients. So when a total laryngectomy patient comes and says that he has some amount of dysphagia, the most common thing you should think of is a stricture. Otherwise, it could be the larynx itself, the laryngectomy neopharynx itself could have problems. So you need to evaluate them well. Skull-based surgeries, most of the time they involve the lower cranial nerves, and if the lower cranial nerves have been affected, then the swallow can have problems, as similar to neurological patients. And most of the cranial nerve functions which are dysfunctional will be at a trigeminal, facial, glossopharyngeal, spinal X-ray, and hypoglossal, and all these have their own problems. And medialization laryngoplasty can help in patients with vocal cord palsies, as we have seen in the discussed with the thyroidectomy case. Now, patients who have tracheostomy also can have dysphagia. This is because they don't have the ability to generate a subglottic air pressure during the swallow. So normally when we swallow, our vocal cords are approximated together, and there's a good enough subglottic pressure, positive pressure, which keeps the vocal cord, true vocal cords together. But when this pressure is lost when you have a tracheostomy, and so then there could be a small gap, gap between the vocal cords, and the patient can aspirate. And of course, the tracheostomy cuff itself is not 100% effective in preventing an aspiration. So you need to be, for a patient with tracheostomy tube, while rehabilitating them, the main thing is you need to focus on getting the tracheostomy tube out. This is not just removing the tube, but basically rehabilitating in such a way that the patient does not need the tube. So you need to discuss with the treating physician when is a good time to decannulate the patient, and that way you can optimize your rehabilitation. The tracheostomy tube is also reported to reduce the laryngeal elevation during swallowing. So I've told quite a lot about how surgery affects surgery for head and neck cancer affects swallowing, and how radiation treatment affects swallowing function. Now, when to commence swallowing rehabilitation? The timing of swallowing therapy is important. There is no consensus in the literature saying the optimal time after cancer treatment to begin dysphagia rehabilitation. Most of the studies suggest that sooner the rehabilitation initiated during the treatment, the better the eventual outcome. So if you are going to be a dysphagia specialist, you need to be there, at least a dysphagia specialist specializing in head and neck cancer. You need to be there when the planning of the treatment at the time itself, because you need to give your input, you need to see the patient, discuss and give a realistic picture to the patient, so that way we can work towards a better quality of life after the treatment. Regarding electrical neuromuscular stimulation, it's, as I told before, it's difficult for most Indian patients to avail this form of rehabilitation in many centers. So instead of that, people have propagated prophylactic swallowing exercise or pharyngosize, and this is a set of swallowing exercises which the patient has to do a couple of times a day and different frequencies before the treatment, during the treatment, after the treatment. This helps to keep strengthening all the muscles of the pharynx, larynx, and oral cavity. And there are enough papers to show, and even a randomized clinical trial to show that these kind of swallowing exercises help patients improve their quality of life and get back to almost normal swallowing. This is a newer advancement where people at University of Keck School of Medicine have actually come up with a hypoglossal microstimulator, which is implanted just before the radiation treatment onto the nearby the hypoglossal nerve at the level of ansa hypoglossi, and this helps to this keeps giving radio frequency pulse to these muscles and keeps stimulating the nerves, especially to keep continuously contracting the hypoglossal muscle and the suprahyoid muscles. This is something like the hypoglossal nerve stimulator, which has been recently used in sleep apnea surgeries. And this type of microstimulator is still under trial, and hopefully in future we will see. So we don't need to push these patients for prophylactic swallowing exercises, because most of the time the complaints is the problem. Patient does not practice it as regularly. And if you have some implantable device which constantly patient can keep just with the press of button, keep getting these exercises done throughout the day, this will strengthen all the muscles of the pharynx and larynx. So in summary, swallowing problems after head and neck cancer treatment need to be dependent upon the extent of resection, the nature of reconstruction, and the structures radiated. There's so much in this. And different methods of treatment for various dysphagia aim to make the patient totally independent of the feeding tubes and improving the quality of life. So we need to individualize the treatment for every patient. And if the treatment was to the subside of the oral cavity, you have to remember, if it's an oral cavity subside patient with head and neck cancer, as the food viscosity increases, the swallowing problem becomes more problematic. So now patient with the oral cavity tumor is more comfortable with liquid because he can use gravity to channel the food down, whereas a solid food is going to be a problem for him. And when the treatment involves base of tongue or arytenoid cartilage, there's a high chance of aspiration. So we need to keep in mind, if the tumor is there at the base of tongue or at the supraglottic, we should recommend the right set of exercises to strengthen the remaining muscles. And besides surgery, postoperative radiotherapy has an additional negative impact on swallowing function by increasing fibrosis of the radiated head and neck tissues. That even applies to primary radiation. And surgery for dysphagia. Now, when regular non-surgical rehabilitation does not work for these patients, then we can think of oncophagous surgery or phagosurgery to augment the swallowing rehabilitation in patients with head and neck cancer, thereby just to improve their quality of life. They still have to have these maneuvers and exercises they still have to do, but surgery can play some role in helping them the quality of life in terms of rehabilitation. So this is one important slide. Swallowing assessment undertaken by certified speech and language pathologists and treating surgical oncologists for head and neck cancers is a team approach. So we need both of them together to plan and individualize the treatment, rehabilitation treatment plan for each patient. So I would like to acknowledge my mentors, and you can see here, many of these people have played a significant role in my training and experience. And thank you very much.
Thank you, Dr. Vidyadharan. It was very exhaustive and very informative. Excellent. I really appreciate your effort in making this presentation. Before I take on all the comments, there will be a lot of discussion definitely on your presentation. I would like to actually take some questions which I had probably missed when we were discussing the last case. So I think Dr. Sanjay, you can also come in. There was a question from Mitali Sharma who wanted to know how long is the Botox in submandibular gland effective? Anybody can take it up actually.
Botox is, as usual, the effect is short-lived. That is one of the main things of Botox. So say 6 to 7 months, 8 months, I think is what I have felt.
Right. Dr. Subhas Garg wanted to know, can anticholinergics help in reducing drooling? I think that Vidyadharan has already spoken about
glycopyrrolate.
Yeah. Then Dr. Subhas Garg again wants to know, do you inject Botox in parotid also?
No, I have not done. I mean, you're not. I think Vidyadhar has already mentioned that you should not do it.
Because the facial nerve comes through, you will end up paralyzing,
paralyzing the face.
Unless we have, I mean, in head and neck patients, the head and neck cancer, they have the psilocybin, collective collection after the surgery or something. That we end up doing, but I've not done for drooling to the parotid. Frey syndrome, yes, Frey syndrome, but that's all different, completely different thing.
Okay, Dr. Phukan had one question. I actually haven't understood it well. Only mucoid saliva helps, he wanted to know. Submandibular gland stimulates. I didn't really get it. I'll ask him again what he wanted. Dr. Mahesh Mohta wanted to know, kindly suggest any book for speech swallowing investigations and rehabilitation. I think you are the experts. You can suggest books.
I think Dr. Priyam Sharma had put in a reference, a couple of books suggested by Dr. Biswajit.
Yeah, this meeting will be there on the LifeMed website. You can actually go back and see those things, Dr. Mohta. I think that takes care. Dr. Kur, now coming back to your presentation. Before I take a direct question on your presentation, any comments from Dr. Sanjay Subbe? I do not see, JKR sir. He must have, his net was unstable actually. He must have gone again.
Yeah. No, as usual, Vidyadhar is very...
Coming back, yeah.
As usual.
Please carry on.
Yeah, as usual, Vidyadhar is very meticulous and very elaborate. So it was very nice. I think he's covered the whole head and neck cancer and what all can happen and what to manage. So it's very nice. Very elaborate expression.
Kumar sir, your comments.
Most of the cases I've done this, Dr. Jaykumar Menon only.
Yeah. Vidyadharan is going to.
While we wait for sir, Vidya, there is a question from Dr. Kudus Ahmed.
Yeah, can you hear me now?
Yes, we can hear you.
Yeah, it was great talk, very elaborate. He covered practically everything of that field, and I was, he was with us in our team, and he still continues to be there. And I see great prospect for Vidya in this particular field because he's a qualified, very capable head and neck surgeon. At the same time, he knows about the swallowing dysfunction. So that's a terrific combination. he is sure to contribute to us our specialty in the years to come. Sure, great.
Yes, Dr. Vidyadhan, there is a question from Dr. Kudus Ahmed. How effective is commissuroplasty after lip reconstruction, given the problem of fibrosis post-treatment?
It depends on the on that patient, sir. If the patient has a lot of fibrosis on the side of the lip, usually fibrosis will contract, and that will make the lip more small. You'll have macrostomia. So then we don't. That's a different type of commissuroplasty where you open it up, kind of thing. Whereas if they have a macrostomia, that's when the saliva starts dribbling out. So I'm not completely sure in what situation audience they wanted to know.
Because if you can put in Dr. Kudus Ahmed in the Zoom panel, he can actually put in the question. There's a question from the Mridul Ali. He wants to know how to manage trismus apart from jaw opening and jaw movement exercise.
So the main thing is managing trismus is preventing it. If all the fibrosis sets in and if the trismus is either due to the masticator muscles, then you need, if the jaw opening exercise does not help, then you need to do a coronoidectomy or something to open up. And sometimes even during surgery itself, we try as a reconstructive surgeon, we don't use a bone flap. If you put a bone flap, and that particular Dr. Maya also is there, if you put a bone flap, that makes trismus more problem because the bone from the lower jaw ends up getting fused to the upper jaw, and that makes mouth opening difficult. So in that situation, we tell the patient also, look, you have trismus before surgery. So we want to make sure we relieve the trismus and take off your tumor. So if we won't put a bone flap, we'll put a soft tissue flap, and that helps the opening of the muscle, that part more. But if it's after treatment, if the patient has trismus, then it's all because of fibrosis. And that's what Dr. Kudus said. So a lot of fibrosis, then we need to keep rehabilitating as much as jaw opening exercises. But beyond 8 months after radiation treatment or 9 months, things are just set. It's not going to open up anymore. It's like leather. So in that situation, we have to go, if the patient really wants, then we need to wait for a year and try to use some kind of a surgical procedure to put in more tissue there to open up that jaw. So it depends again on the patient, and the main thing is to prevent trismus. So you need to know what are the things which are going to cause the trismus and try to keep pushing the patient to do these exercises and keep telling the truth. Look, if you're not going to do your exercise well, you're going to be not opening a jaw, and then I cannot do anything. And it's pretty gruesome. I need next time take a picture. Sometimes in the operation theater, we put the patient under anesthesia and just pry the jaw open. And these are the videos the patient will not like really. When they see that, they will do the exercises well. I'm pretty sure of that.
Yeah. There has been a lot of comments praising all the speakers for their excellent deliberation and for your Vidya's very detailed talk. Vidya, you had given a comment about oral submucous fibrosis about North India. I know it's more in North India because of gutka and all that. It's also there in our parts as well. But in South, you get very less cases of OSMF?
Yes, sir. I think that habit, I think now it's changing a bit, but the habit is not, the pan chewing or gutka chewing habit is not there. There is areca nut chewing habit, but for that, the patient will have affected only one side. But the pan and gutka, when they just keep it all around the mouth, the whole area, the whole field gets affected. So that's the thing. So,
I think submucous fibrosis is coming drastically down in Kerala because the habit of chewing has practically gone.
And they banned gutka in at least my state, at least. It's still illegally people who get it.
There's one more question from Swapna N. What is generally done to overcome taste and smell issues in patients post head and neck surgery?
Taste
and smell issues.
So if the patient has xerostomia, then they will have taste problem also. So, and also chemotherapy can cause a lot of problems with taste as such. So it will recover eventually. We need to just reassure them and try to ask them to keep drinking as much as water. And hopefully, maybe the future, there's not much research into it, but this lymphedema of the neck because the taste pathway is either to lingual nerve or the chorda tympani. And if there is internal lymphedema of that particular area, then that nerve is going to be affected after a long time. So we need to make sure manage the lymph. I'm just speculating. Maybe manage the lymphedema as much as possible. But taste patient do get back after some time. Loss of smell, it depends, unless they've had a cancer surgery of the maxilla or of the endoscopic skull base somewhere where the olfactory fibers have been transected, then you're not going to get back. Jake Mercer can give some input also, sir.
For the taste and smell? No, I don't think I have nothing much to add to it. Whatever you are told. Yeah.
Maybe steam inhalation. Sometimes it could be compounded regular allergy, inferior turbinate hypertrophy. Those things, if you manage that as an ENT surgeon, take a look. Refer to an ENT surgeon. Let them see if there's the mucosal hypertrophy somewhere. If all that is okay and still patient has thing and he's had some surgery or some radiation at that point, then it's a bit difficult.
For smell, I mean, they say classify not head and neck. It's like conductive and sensory neural.
Okay.
Conductive anywhere in the airway, like you can other polyps or polypoidal hypertrophy, you can manage. If it's sensory neural, means it's where the nerve is affected, then chances are recovery is less. So it's the same. COVID also, we are seeing some smell issues. So it's the same concept.
For a person who's having taste and smell affected, they will have they won't have any interest in food because they can't get any flavor. Everything tastes like cardboard for them.
You smell the food first and then you taste it. So that smell is lost, the taste also is gone. Flavor of food is gone.
But the major problem actually when we get patients with anosmia, apart from what you have said, is the danger. With the gas stove being on, they do not see that the smell is there. So that danger is actually very much. Dr. Kudus Ahmed sir has come into the Zoom meeting. Hello. Sir, could you unmute yourself, sir? Sir, could you unmute yourself, sir? Sir has not unmuted himself. Anyway, we are requested sir to come in because he's been a mentor for most of us to, sort of discuss with you that query that he had put.
Fibrosis and commissioner plastic.
Sir, your mic is off. Can you unmute? Now Biswajit is calling. Any more comments? Actually, there are more praises than questions on the.
Question in the
new question
in the chat box, sir.
I missed it.
Yes, sir.
Oh, Pritam has asked, yes, how to manage. Yeah, your voice is breaking. Vidya, the question is from Dr. Pritam Chatterjee. He's from Kolkata. How to manage xerostomia post-radiation medically?
They have a lot of...
Post-article.
Yes, the answer is salivary substitutes. If you ask the radiation oncologist, they will tell you there are different brands. We use a brand called MWET. There are different types of salivary substitutes which you can use. Drinking water helps, and sometimes I suggest my patients to add a little bit of neem in the water or cardamom. It's a little bit flavor in the water keeps them, that stimulates salivary secretion. Lime or citrus fruits, but it depends on how much it burns. Some people have mucositis, they cannot have any citrus fruit. So what works for them? But medically, pharmacologically, they have salivary substitutes. So you can ask the radiation oncologist, they'll tell you what are they.
Yeah. I had heard a presentation on saliva, submandibular gland transposition before radiation. Is this very popular? Is it been practiced regularly?
No, sir, I have not. At least I've not heard of that.
There was I forgot
a paper, but I've not. I don't think people are practicing. Why would you put a patient to undergo a surgery and then it's a bit more complicated for the patient, especially our Indian patients are not feasible.
Right. Kudus Ahmed sir is again back. Sir, could you unmute and Vidyadharan wanted to hear from you. What the query, sir? Sir has been not been able to.
Okay,
unmute.
okay.
Yeah, we can hear you, sir. But we cannot see you.
Okay. Actually, the problem. Wait, just a minute. Now I don't know.
Yeah, we can see you and hear you.
Okay. The question I asked was about commissuroplasty. We've had a lot of problems with these forehead flaps where huge bulky flaps used to come in. And by the time we get through the treatment, the commissuroplasty becomes very difficult because of sometimes it's the bulk, sometimes it's the fibrosis.
Okay, sir.
But most of the time we find it difficult.
Is it the patient have a big mouth or do they have a small mouth, sir? Macrostomia?
It's mostly macrostomia, which reduces to an extent.
Okay. So it depends. Usually we wait about a year or 18 months after the full treatment is done. Patient is a bit tumor free and a little bit better before we go and open up that same area again. So because as we open up, there's more fibrosis going to come in. So if we have the macrostomia, then if you wait for a year and then that the tissue will stop shrinking and all the fibrosis is actually achieved, all done, then we can go in and do a commissuroplasty and reduce the size. So you can take off a little bit. If it's bulk, it's always anytime we can just put a small pocket, try to take out a bit of the fat or defat that particular area, and then you can suture it back. But ideally, wait. Yes, sir.
Yeah, we haven't done many, but those which we have done, it was so hard that the tissues would not heal once you put your knife in.
In that situation, we need to put in a little bit more tissue, take off that scarred area, put in a little bit more tissue somewhere, either a nasolabial flap or some other local flap. If you put in that tissue and then make that commissure again. Initially you're not worried about doing the commissure. You're worried about taking the tumor out and closing that defect. Now you're doing the fine tuning work. And
we've had this problem more with the forehead flap, actually, like you showed.
Yes. Okay, sir. Maybe it depends upon, I guess, each one's forehead, I guess. Yes,
yeah. So we've started doing foreheads.
Actually, to be honest, this particular flap was done by Dr. Subramania Iyer, and he, as a team now, he does all the finesse work now over there because the rest of the team does all the major work. He does this fine nip and tuck, and so he did it. So it's one of his patients. He's been kind enough to allow me to use it.
So I always get somebody to do my reconstruction.
Yes. So you could tell them preemptively itself while doing it itself. Try to add a little bit extra flap later on. It's better to cut down the flap than to stretch it later on.
Yeah. Thank you, sir. Thank you, Dr. Vidyadharan, for your nice talk, and thank you, Dr. Sanjay, for being with us and accepting our invitation. And thank you, Jaikumar sir, for spending the time with us. I remember it was about 12 years ago, around 2008, when we first invited Jaikumar sir to do a workshop in Guwahati. And sir didn't ask me that I didn't have a VLS system in my hospital. At the time of the surgery, suddenly saw it's a microscope. He said, I haven't done microscopic laryngeal surgery for a long time. But we did a large number of cases, and that was the time sir actually gave a very excellent lecture on swallowing, which actually opened our eyes on the swallowing lecture. At that time, sir's lectures here and there on swallowing actually sort of created the awareness about this problem of swallowing and the science of deglutology, and it has grown now to this extent. And I think the awareness is increasing. And thank you all very much for participating and being here to encourage us. It's been a very nice evening.
And thank you for the opportunity, sir. I would have loved to come to Guwahati. I mean, this because of this virus, now we have made it webinar. It would have been nice to have been there. I know you're very hospitable. Yeah.
Before we disperse, can I make a comment?
Yes, sir.
Hello?
Yes, sir. Yes, sir. Please, sir.
Yeah, we had a lot. I'm so happy to see that the deglutology is fast developing. And one area which was not covered here, we will be covering next Sunday. So I invite all of you for the Kerala State Branch APS ICON on 13th. So it is from 8:30 to 1:30 on 13th. It is actually 2 Sundays. Next Sunday, 13th, this is purely pediatric and neonatal deglutology.
Excellent.
From 8:30 to 1:30. Ravi Elluru from Cincinnati will be the international faculty. And we have faculty from Mumbai, Gayatri Hattangadi, Sherin Edikula from Bangalore, Jayanti from Cochin, Naveen Jain from Trivandrum. So it's a thing, and we have made it more interactive session. So people will be presenting difficult cases of pediatric swallowing disorder and how we should manage. So rather than going for many lectures, we have kept like that. So pediatrics, so one area which was not covered today, we will be covering next Sunday. So invite all of you on behalf of Kerala State APS ICON.
Sir, please give us the link. We'll circulate it throughout all our friends. And now I call upon Dr. Anjana Talukdar to give the formal vote of thanks.
Thank you, sir. Thank you, sir. Everything has to come at full stop. But I didn't know that our first anniversary was such a big band. It was a really success. And thank you, everyone. And my sincere thanks to Dr. Jayakumar Menon sir, Dr. Sanjay Subaya sir, and Dr. Vidyadharan S. for accepting our invitation and sharing their valuable experience and expertise. I also thank our senior teachers, Dr. S.V. Fukan sir and Dr. Kudus Ahmed sir, for constantly guiding us time to time. I thank all the viewers and Pratiksha Academy members for constant support. I also thank Manarini India Private Limited for their support. Finally, I leave you with this inspiring quote by Martin Luther King. An individual has not started living until he rises above the confines of his individualistic concern to the broader concern of all humanity. So let's start our humanity. We'll continue our humanity activities. Good night. Take care.
Thank you, sir. Goodbye.
Thank you.
Thank you, sir. Good night.
Thank you, Priyam. Bye.
Thank you, sir.